All right, we'll go ahead and get started. We're running just a couple minutes late here, but want to call the meeting of the Behavioral Health Reform and Innovation Commission meeting to order. Appreciate everyone being here. And I want to say in the start of the meeting that I want to thank the subcommittee chairs and all the subcommittees because having been involved in public policy at some level for over 32 years now at the local level and state level, I've never saw a group of people work harder for a common cause than I have over the past 12 months. You all have met numerous times in subcommittees, both in person and virtually. The information and sharing of ideas has been phenomenal. And I just want to thank the dedication that all of you have had to the people of the state of Georgia. So thank you for all you've done. And we're going to get to see a lot of that play out today with the presentation of some of your recommendations. But as we start, I do want to thank you for all you do. I also want to congratulate and thank Regina. Regina Quick is in the back of the room. She's taking over general counsel at DHS, but Regina has been a friend of mine for a long time since we came in the Georgia House together and did a wonderful job at the Lieutenant Governor's office and really was instrumental in House Bill 1013 and getting that through the General Assembly. And she's a great asset to us. So looking forward to working with her in a different capacity, but I want to recognize her for being here. So with that, we're going to get started. And the idea here today is each subcommittee is going to have a section of the agenda. The subcommittee chair will present anything they want to present. And then there's some speakers in these subcommittees. And then the subcommittee chair will wrap up that section. And our hope is at the end of the meeting today, we've got a list of recommendations coming forward from the subcommittee that then we can take up, have conversations about, and then ultimately prepare a report that we're going to produce for the governor and the General Assembly. So with that, first up is mental health courts and corrections. Hold on just a second. All right. Justice Boggs had let us know he's going to be running a few minutes late. So we're going to go ahead and turn it over to our Children and Adolescent Subcommittee and their subcommittee chair to make opening remarks and then to present a presentation to us.
Good afternoon. I'm Eric Lukowitz, and it's a pleasure to be here today in front of all these distinguished individuals. When we started this subcommittee this year, we had a rather ambitious agenda because we saw some issues that needed to be rectified. We focused initially on substance abuse, which we thought was grossly under treated. We also looked at autism because there's unique challenges to that population. So that was a big deal. And we brought in some national experts for two of these. The last one, I'm trying to remember. I've got my list here. Okay. Oh, the other one, which was infant psychiatry, which was a big deal. And I know that was initially in the original HB 1013, but it sort of was a late scratch in the Senate. So I want to make sure that today that I get across the importance of infant psychiatry. And when I get to talking about that, I'll make some additional remarks. I had tremendous assistance from Dr. McGibney, who's to my right. I don't think I could have done this without him, and lots of others contributed admirably. So let me go ahead and start. No, I know we had slides, but I don't know that I don't know if we need to use those. I sent them to people, but I'm just going to go ahead and talk about my recommendation. So the first recommendation that we thought, because of the prevalence of mental health issues in children and adolescents. And there's two statistics that I think you should know if you don't already. that 50% of mental illness begins before the age of 14. So that's a big deal. The other number, if you remember two things, is that last year in Georgia alone, there were 119 suicides. So, so that has driven a lot of our thoughts. And we believe that if we treat mental illness at an earlier age, we can change the trajectory of the illness and prevent people from getting chronically disabled to the point where they're no longer are as productive to our society. So one of the suggestions that we'd like to make, and I'm going to talk about different things and make suggestions at the same time, is to create an executive leadership position, such as deputy or assistant commissioner at the Georgia Department of Behavioral Health and Developmental Disabilities, because there's so much going on in child and adolescent psychiatry and mental health that I think they will help the commissioner make better decisions going forward. So I'm going to move on. That's just a generalized topic. My next topic would be mental health and substance abuse treatment and resources. So we want to expand evidence-based substance abuse and mental health treatment for co-occurring disorders with integrated treatment models, co-located treatment services, and coordinated care models that community-based resources can provide the essential services. So I think you're all aware that we have community service boards here in Georgia that are sort of the safety net for mental health. But there's maybe some improvements that can be made to support the community service board, to encourage them to provide more comprehensive services. And each one, there's a lot of variation. Some community service board do an admirable job of tackling all areas of mental health issues, and others, in my opinion, abdicate some of their responsibilities. And I think if we can encourage them to be a little more inclusive in their services, that will be beneficial to all the citizens of Georgia. We want to expand access to telehealth for mental health and substance abuse. Now, I do want to acknowledge that the mental health bill that was passed in Georgia before the pandemic actually is one of the best in the country. And so, being a practicing psychiatrist, it enabled us to continue to treat patients throughout the pandemic when our clinic was closed down. So I think it's a great model. There are some slight limitations. Some of those are due to current federal laws. There's the Ryan-Haight Act, which prevents us, will prevent as of January, because we're still under emergency authorizations, but we won't be able to prescribe stimulants or controlled substances without seeing the patient first. So I've actually contacted the two senators' offices to see if we can get them to consider supporting legislation to reverse that. The other things we want to make we want to enable people to be able to get prescribed buprenorphine, and buprenorphine is the best treatment for opiate addiction. And it's kind of complicated because doctors can't prescribe buprenorphine without getting special training called X-waiver training. And the benefit of buprenorphine is not only does it prevent the withdrawal of opiates, but it also helps prevent craving, which is what makes it superior to all the other treatments out there. So to be able to do that through telehealth would be a wonderful thing, so that we could reach people in the rural areas where they don't have as ready access to care. We want to increase mental health and substance abuse treatment provider pay to bring more therapists into the service network. And it's my understanding that the Department of Community Health is currently undergoing a survey to look at surrounding states and try to bring us more in line with how they are in surrounding states. I understand that in Virginia, just by increasing provider pay, they were able to almost eliminate the workforce shortages that they had there. So that's pretty amazing. I do want to talk about warn the legislature and policymakers to be careful about potentially legalizing cannabis in Georgia. We brought Dr. Paula Riggs, who's the head of the substance abuse services at the University of Colorado, and she's one of my mentors. And there have been so many problems in young people because when you legalize cannabis at the for adults, it makes it much more readily available for children and adolescents. And in children and adolescents in the developing brain, it causes more paranoia, increased risk of psychosis, even things like cyclical vomiting. And we already know about amotivation syndrome, which is not good if you're trying to go to school and graduate. So we want to caution the legislature about legalizing that. Next, want to talk about closing the gap of mental health and substance abuse services and treatment that exists between our CMOs, Amerigroup, Georgia Families 360, CareSource, Peach State, and DBHDD by developing a coordinated plan of continuum of care. So again, we want to eliminate people falling through the cracks, and that's been one of the issues with our current system. We want to expand the number of crisis stabilization units. The ones that are there are, I hear good things about, but they're very minimal. And we learned about them through our subcommittee. We want them to cover more regions of the state and provide information about them to people who might utilize them, such as the community service boards, pediatricians, emergency room physicians, and add to the Georgia Crisis and Access line. Next, we'd like to expand the availability of child and adolescent substance abuse intensive outpatient programs to more regions of the state. So I think right now they're just in two parts of the state. And as I like to say, I'm from Augusta. Georgia is more than just the Atlanta suburbs and the metro Atlanta area. So I feel beholden to represent those people's interests. We want to study the possibility of expanding the number of substance use disorder intensive residential treatment centers that present from the present 2 facilities to more locations in the state. So again, I had a 17-year-old who purchased what she thought was not Valium, one of the benzodiazepines on the street, and it turned out it was laced with fentanyl. So she ended up addicted to 2 drugs at once. And I tried to get her into treatment. Nobody in the area and the Augusta area would even consider seeing her. So that was a terrible thing. We want to expand the number of clubhouse programs that provide continued care for adolescents recovering from substance abuse issues. And that's the transition from acute detox and initial treatment to help them reacclimate to the community. And I used to actually run an intensive outpatient program when I was in private practice. And what the hardest part was leaving the intensive outpatient program and going back home where you have your friends who are mostly using, and you go right back to the same process. So that's why these clubhouses are so good. And some of them are based on the 12-step model, which is well validated. And children and adolescents do wonderful in groups. So I think would be a good use of resources. Right now, there's only one facility that offers transition age youth services. So children sort of skirting the line between adolescence and adulthood. And as you well know, that is a difficult process in and of itself. And if you compound that with some sort of mental illness, it becomes very, very difficult. And a lot of these kids would end up either homeless or being trafficked. So that's another reason. I know that Amerigroup has started some work to have a program for transitional age youth, but I think more needs to be done. We want to recommend the expansion of juvenile drug courts to more jurisdictions and link them to community-based resources. I mean, they've been very successful with the adult population. I know that in Augusta, we don't have that, and it would be nice to see that there. And it might be one way to keep them out of the juvenile justice system, which is, as many of you know, the largest single mental health provider in the state for children and adolescents. Now, I want to talk to you. So this is actually number 14, but there's currently 2 child psychiatry access programs in Georgia. And what child psychiatry access programs do is we actually, I'm a part of one of them. We train pediatricians, family medicine doctors, nurse practitioners, and physician assistants to handle more complicated mental health issues, including, of course, prescribing, but also teaching them how to do psychotherapy of different kinds. And so right now there are 2 in Georgia. There's the Georgia Pediatric Psychiatry Consultation and Access Program, which is done through Children's Hospital of Atlanta, and then the Georgia Mental Health Access and Pediatrics, and that's the one that I'm affiliated with, which is a collaboration between the Georgia Association of American Association of Pediatrics and the Medical College of Georgia. And so right now we have, and they're both administered by the Department of Behavioral Health and Developmental Disabilities. It's through a HRSA grant, that 5-year HRSA grant. So after 5 years, they'll dry up. And I've been a member of a national organization of groups that do this across the country. And they do a wonderful job when they're able. But some of the states, like Arkansas, for example, which had a thriving program, after 5 years, it dried up and went away. And then the legislature was not interested in renewing that. So that would be really a shame. Just this year, I've trained, I think, 24 pediatricians. That was our initial thing, and we're going to be doing a consultation line as well. So, and the folks from CHOA are doing the same thing. So if we could figure out a way, and I know there's states like Pennsylvania that have forced private insurance to pay into a fund to support such a thing, along with Medicaid, and it's worked very well there. I think Wisconsin has a similar model. So I would recommend exploring that to ensure that it doesn't dry up after 5 years. We'd want to recommend seeking a 115 waiver to allow a portion of Medicaid funding to be used to address social determinants of health. Children from lower income families are disproportionately exposed to a combination of health risks, such as poverty, violence, unsafe living conditions, and environmental health risks, and that increase the need for healthcare interventions. I see Emily Vale in the audience, and she is with Resilient Georgia, and they've been a huge advocate to spread the word about adverse childhood events, or ACEs. And what the importance of that is that when children are exposed to trauma early in life, it predisposes them to more persistent mental health and physical health issues in life. So I always thought that if like schizophrenia didn't run in my family, I was not really at high risk for developing it. But it turns out that if I have a traumatic childhood, which I'm not sure if I did or not, but I seem to have made it okay, that I'm at higher risk for not only mental illness, anxiety, depression, maybe bipolar disorder, ADHD, but also physical things like heart disease, stroke, lots of things, diabetes. So in other words, if we can minimize, find ways to prevent trauma early on, and then that would go a long ways to helping decrease the need for mental health services in adulthood. Okay, so we should offer operationalize the Georgia Student Health Survey data for use by stakeholder decision makers and citizens by making it a query database, perhaps created by the Georgia Data Analytics Center for the purpose of identifying I lost my point. 1 second. Identifying mental health needs of school-aged children and adolescents. So that would be useful. We would like for public and private schools should consider establishing school-based plans and toolkits that help enable eligible students and family members to enroll in health insurance that includes mental health coverage and telehealth access. Schools should explore the use of telehealth for physical and mental health services. And I know that the Department of Education is actually working on setting up school-based clinics across the state to handle both physical and mental health. So they are already moving in that direction. School districts and regional education service agencies should collaborate with local community service boards to develop coordinated mental health access to students, such as expanding the APEX, wildly successful APEX net program to include mental health and network access information sessions for students, staff, and parents. Schools should partner with federally qualified health centers to offer integrated health services access to students and families. We should continue funding for the mental health training initiative through the Department of Education, RESA and NAMI that provides mental health and trauma awareness training for educators. Now, my next section is about mental health, substance abuse, and prevention. We want to expand prevention clubhouses to add more regions to the state to broaden each of this successful program. Expand the source of strength prevention program that combines community work with school efforts to empower children, adolescents, to provide support for mental health and recognition of the importance of family support access to services, spirituality, generosity, mentorship, and health activities. Next, we'd like to expand substance about prevention activities in schools and colleges and include community resources to aid the development and expansion of prevention programs and activities such as the peer assistance, student transition program, college prevention program, and Let's Be Clear program. Expand the certified student peer support specialist program to include more schools and linked and community-based programs. And we had peer support specialists at our institution, and they were really helpful in helping negotiate the system, encouraging people to utilize services that are readily available. My next section is going into infant mental health. And again, as part of, we wanted to reiterate the support for the Child Psychiatry Access Program beyond the 5-year HRSA grant. We want to support high quality early childhood programs that give children a safe, stable environment. We want to support evidence-based home visiting models that can provide information and support from parents. That would be in an attempt to decrease the potential for trauma that we talked about earlier. We want to support evidence-based home visiting models. Okay, that's good. Provide funding for training on early childhood trauma to members of the child serving workforce. So many of you know Judge Peggy Walker, and she was so frustrated with her inability to get services for her young children that she actually went to Washington, D.C. and trained to become a 0 to 3 provider. And then she came back and trained all her staff to treat children's mental health, which is just incredibly inspiring. We want to support the workforce in getting child and parent psychotherapy endorsed by Georgia AIM. They work with infants. I can't remember the whole acronym. I should have prepared better. Develop and support strategies and implementation to expand the state's capacity to provide access to CPP statewide. Enact policies that support infants and children's caregivers who are experiencing stress related to housing and income support. Consider case management services. And we want to ensure Medicaid reimbursement for prevention and treatment. I think expanding Medicaid for mothers up to a year is a good start. and I'd like to see that continue because it doesn't postpartum depression doesn't magically go away after a year. We want to expand support for neonatal intensive care units by investing in the regional perinatal center neonatal outreach educators coordinated by the Georgia Department of Public Health. And the point here is, and I'm going to try to make it as simple as I can. When children are in the neonatal intensive care unit, routinely they are separated from their families, and at a critical time when bonding takes place. And so some rather innovative institutions have recommended using like telehealth to make sure that the family was involved on a regular basis to continue the normal process of bonding, even though they're in a pretty restricted area. So we want to include family integrated approaches into care in the NICU as part of the university and professional training for all types of practitioners who provide care in the NICUs, including but not limited to nursing, medicine, social work, counseling, and allied health. Embed practices in the NICU that encourage and support families to read aloud with their infants while in the NICU, to promote private-public partnerships with hospitals to help with the cost of books. By reading even to children that early, it helps promote language development that might otherwise be impaired by separation from the family. We, support efforts like Reach Out and Read in the pediatric setting, so families will continue to be encouraged and supported to read with their infants throughout early childhood. Expand implementation of NICU peer-to-peer support provided by parents who have experienced having an infant in the NICU to those who currently have an infant in the NICU. That's a great idea. Expand access to training and implementation of NICU peer recovery coaching to reach families impacted by substance use and to improve coordination and monitoring of plans of safe care. Develop and implement an approach during the NICU stay to create a plan of safe care with families impacted by substance abuse. Include coverage through health insurance to address social determinants of health, transportation, parking, lodging, meals costs, missed work pay, lack of child sitting for siblings to increase families' ability to engage in the care of their infants while in NICU. And it really is critical. There's just a narrow window where if you don't have that presence, you risk not having that. Increase resources through private-public partnerships that support hospitals to provide on-site childcare facilities for siblings to help remove the barrier of securing and paying for sibling children. Provide resources for hospital systems to proactively develop innovative solutions that facilitate and support the family's presence in the NICU. These solutions could include providing a place for the parents to stay and take care of their basic needs, such as eating, bathing, laundry, and sleep. Vouchers for lodging and meals would significantly reduce the financial burden of staying long periods in the NICU. Increased resources, so technology-based approaches can be implemented to implement families' physical presence in the NICU, which may include text messaging updates, webcam footage of infants, FaceTime and Skype updates, virtual visitation, and virtual rounding. So that's for infants. Moving on, the next area is we're getting there. Autism spectrum. So I've told you it was an ambitious agenda. So I'm delivering as I promised. So provide case managers from Medicaid or commercial insurers to parents to help them find and best utilize services, develop medical and psychosocial protocols as immediate follow-up after an autism spectrum disorder diagnosis, which should include respite care. Insurance companies should be required to recognize a diagnosis of autism spectrum disorder from a primary care doctor or child psychiatrist while waiting for the psychological evaluation, which would allow immediate access to applied behavioral analysis treatment or ABA. As it stands right now, you have to have testing, which may take 18 months to get set up. So it's a really again, it's a time critical process. All right, so the study how schools should train more teachers and paraprofessionals on autism spectrum disorder. Study how paraprofessionals could receive training as a registered behavioral technician. And those are the people who actually provide ABA therapy. Develop more acute autism crisis stabilization units funded by a combination of federal and state funds and reimbursements from Medicaid insurance companies. Currently, I think there are 2 facilities that take children with autism, with an autism diagnosis in the state who are in crisis. And as a result, those beds are continuously full, and these children languish in emergency rooms for days to weeks. And you can imagine that's not a good situation. Let me find where I am here. Study how to create incentives to open more residential treatment facilities for acute autism spectrum disorder. State needs to give more resources to the Medicaid waiver program to get autism spectrum disorder patients off the waiting list. And there should also be a reevaluation of Medicaid reimbursement rates for autism spectrum diagnosis and remove the restrictions on who is qualified to make a diagnosis, as it's also recommended by the American Academy of Pediatrics and the American Academy of Child and Adolescent Psychiatry. And last, and one of the glaring omissions that we have seen is that psychologists cannot bill for the initial diagnostic evaluation like is common in a lot of states. So we recommend that the Department of Community Health consider a feasibility study for reimbursing psychologists for a 90791, which is a diagnostic evaluation, and in the hopes that it will encourage more psychologists to practice in the state of Georgia. And that is the end of my my presentation.
Wow. A lot of information. One of the things that I know we didn't print out the entire packet for everyone that was emailed out, because it was not just your presentation, but all the presentations were getting close to 400 pages total. So you will have all this information in your email. And I know there's a breakdown. I have it here in front of me, a breakdown of all your recommendations that you just went through and some additional ones. And it's also broken out if it requires legislation consideration, budget or grant implications. It's just a policy from the department or a practice consideration from the practitioner. So it's broken out. A lot of the things you talked about does not require legislation. Some of it's budget related, some of it's just department related, some of it's the way people practice medicine, et cetera. So there's a good chart there that breaks all these recommendations out. So
we couldn't have done this without the help of I call them the Anns, Ann Girolamo and Ann Mukherjee at the Georgia State University Center for Mental Health Excellence, Child Mental Health Excellence.
Yeah, and I want to recognize them also and just thank them because and DHS for providing the funding through OPB helping find that funding with DHS to provide their services. That's been invaluable this year and will be invaluable in digesting this information today and ultimately helping us produce a report to the public and to the General Assembly and the governor. So thank you. Any questions of the Child and Adolescent Subcommittee? Again, I know that's a lot of information. They put a lot of work and a lot of meetings into this effort and have members of that subcommittee who are experts in this area. So any questions? We'll be able to tell if anybody's on. All right. We're also able to tell if there are any questions from online. We don't see any. So if not, we will continue to move forward with the agenda. And we're going to go back up to catch Chief Justice Mike Boggs. So Chief Justice Boggs.
Thank you, Mr. Chairman, and members of the committee and members of the audience. Thank you for being here today. Before I call on those that have provided technical assistance to my subcommittee, I want to thank my committee, the Mental Health Courts and Corrections Committee of this commission, and also thank the advisory committee members of the Familiar Faces Advisory Committee. The bulk, the entirety of the recommendations that we will be making today come from the Familiar Faces Advisory Committee. You all have, I think, a PowerPoint presentation that I'll call on the Justice Center momentarily to present. For the benefit of the audience and for benefit of folks that are not particularly familiar with the issue of familiar faces, or even writ large, the entire conversation that we have about this population that has behavioral health issues and their interaction with the justice system, I thought I would start off with some statistics that I think you will equally find alarming, as others have when I've mentioned these to them. So let me start with, before we get into the PowerPoint, a couple of statistics that I think are important to understand. In the United States, in 2017, counties spent $80 billion on their local correction cost. An estimated 2 million of the near 11 million annual jail admissions annually involve a person with a serious mental illness such as schizophrenia, bipolar disorder, or major depression. Nearly 3/4 of those individuals that are admitted to those county jails also have a co-occurring or substance use disorder. We know from plenty of research that people with psychiatric disabilities are overrepresented in the criminal justice system at 2 to 6 times the rate of the general population. Among jail inmates, as many as 17% of the males and 34% of females in jail populations may have a serious mental illness. We know that reducing the incidences of mental health inmates in our county jails likewise affects our Department of Correction population. For example, in 2015, Georgia had an estimated 451,000 persons under community supervision. Of course, we led the nation with that number, but we also had 88,000 people incarcerated in county jails or state prisons. In 2016, there were about 9,000 inmates at the Georgia Department of Corrections with a diagnosed mental illness, 1,400 of which were actually receiving treatment prior to their incarceration. We know that federal and state policy and funding barriers, along with limited opportunities for law enforcement training and arrest alternatives in many communities, have resulted in county and other local jails housing more people with mental illness than state mental health hospitals. We know that people with mental illnesses in jails were arrested for relatively minor crimes, such as loitering or causing public disturbances. But we also know that research shows that incarcerating that population often exacerbates their symptoms and can also lead to significant likelihood of recidivism, thereby adversely affecting public safety. Interestingly, we also know that once incarcerated, this population is expected to spend, get my numbers right. Once incarcerated, this population tends to stay in jail longer and are higher risk of reincarceration than people without these illnesses. We know that our local jails in Georgia and elsewhere spend an estimated 2 to 3 times more money housing people with serious mental illness than they do on people without mental illness. We know jails are the most expensive and the least humane way to house many that are included in this population. In many jurisdictions, the decisions that they're having to make result in their county jails and in many instances, the state prison system becoming our de facto mental health hospitals. So as a baseline for why the Mental Health Courts Corrections Committee is really engaging in this very important work, I want to then pivot to this concept of familiar faces. Familiar faces is a term we use to define folks that law enforcement encounters on a regular basis in their local communities throughout Georgia and throughout the country. Some statistics that are just alarming to me when you talk to law enforcement about this population, about their interactions with this population. There are some really common threads. I'll give you one example nationwide. Judge Amaro and I have had the pleasure of being around a really, I think, a stellar individual and a person that's leading on this front, Judge Steve Leifman, in Miami-Dade County, Florida. But the problems that Judge Leifman experiences in Dade County are not immune to Georgia, and are not isolated in Miami-Dade County. In fact, we see these sorts of statistics across the country, even here in Fulton County. But one example of a familiar faces issue is that I'll relay to you before we get to the presentation is that over a 5-year period, Miami-Dade County looked at about 3,300 people that law enforcement had had asked for a mental health evaluation, people that had been arrested, but that they believed needed a mental health evaluation. They narrowed that list of 3,300 people down to 97 individuals, 97 people in Miami and Dade County, Florida. 97 people with serious mental illness who were identified as heavy users of acute care and institutional services. You should know that those 97 people accounted for 2,200 bookings into the Miami-Dade County Jail. They accounted for, over a 5-year period, 27,000 days in jail, 13,000 days in crisis stabilization units, state hospitals, and ERs. They cost the taxpayers in Miami and Dade County nearly $17 million. And as we all know from the studies that have been conducted, empirical objective studies, they had little impact on reducing recidivism or any return on that public safety investment. That study has been updated, and now from 1985 to the present, we know in Miami-Dade County that those 97 people were arrested 4,210 times. They spent 97,438 days in the Miami-Dade County Jail. 92%, not surprisingly, of that population was homeless, which is going to account for some of the statistics, some of the recommendations that my committee makes. And so far, those 97 people in Miami and Dade County have cost about $26 million to taxpayers. Taxpayers might very well be interested in investing $26 million in remediating a population of 97 people. The challenge has been that there is no remediation, there is no improvement to public safety, and nothing largely is being done with respect to the moral imperative to those individuals or the fiscal imperative to the state taxpayers. So we know that the issue of a small population driving a lot of law enforcement impact, driving a lot of fiscal and budgetary considerations for state and local communities is significant. And so I have tasked my subcommittee to really come up with some recommendations to address familiar faces in Georgia. And so you're going to hear from the Justice Center momentarily. I'm going to turn it over to Hallie Fader-Tao in a moment, but just to give you a capsule summary of our recommendations, they fall into 4 categories. The first category is that we're going to make recommendations that we think will bolster capacity to identify this population, because one of the challenges we have, probably with above all, Dade County was able to identify these 97 individuals. But if you ask law enforcement in Georgia, if you ask sheriffs in Georgia who run your county jails, how many people do we currently have in Georgia in our county jails that have a serious mental illness? And the answer is nobody knows. And that's because everybody defines it differently. Everybody talks about it differently. Some people screen for it, some people don't. The truth of the matter is we just don't know the breadth and depth of the problem. And so part of our recommendations is starting really at ground zero. What can we do to help identify? So first area of recommendations is going to bolster our capacity to help identify this population. Our second area of recommendations is going to include recommendations to improve the community response to that population. Third, and appropriately, I think, our recommendations are going to then talk about how do we expand access to high quality care and supports for this population within the community. And then fourth, and very importantly, from a judge's perspective, at least I will say, I think it's very important that decision makers, judges are decision makers, that decision makers have a full picture of the individual with whom they're dealing. And we don't in Georgia, because we don't share information among state agencies. We don't share information between branches of government. We have, in some instances, some very good, valuable information. Judge Amaro doesn't know most of that information at the time he is sentencing individuals, because we don't have information concerning psychiatric care in the community available on our GCIC rap sheets, if you will. And so those are the 4 areas that the PowerPoint is going to present. It's not a long PowerPoint. It's only 26 pages. We don't have an enormous number of recommendations, but those recommendations fall into those 4 categories. So if Chelsea's here, are we ready to pull up? Okay, we're ready for Hallie to present the PowerPoint at this time.
Thank you so much, Chief Justice Boggs. Can you all hear me okay?
Yes.
Excellent. Thank you. Well, it is, we are very grateful for the opportunity to be here with you all. Thank you, Chair. Thank you, members of the Commission. Thank you, Chief Justice Boggs. My name is Hallie Fader-Tao. I'm one of the Deputy Directors for the Behavioral Health Team at the Council of State Governments, and I oversee our work on state policy at the intersection of criminal justice and behavioral health. For those of you who are not familiar with CSG, the Council of State Governments is a national membership association for the 3 branches of state government, and we try to provide research, share information to support policymakers in their decision making. It has been a pleasure to work with the advisory committee over the last 6 months, and while me and my team will be sharing this information, it is really the result of hours of work on behalf of hours of work by state and local policymakers and community members in Georgia who have shared their experiences with us and helped us develop an understanding of what's happening and what might be practical strategies to improve outcomes for this population. Can I have the next slide, please? As Chief Justice Boggs said, we will do a little bit of an introduction to Familiar Faces and the advisory committee, just so that you have some context for where these recommendations come from. And then we'll go through recommendations in the 4 priority areas that the Chief Justice just went through. Thank you. Next slide, please. So, yeah, thank you. As the Chief Justice said, when we're talking about familiar faces, we're talking about a population with complex needs who often have frequent encounters with behavioral health services, emergency services, homelessness systems, as well as the criminal justice system. So this is a subpopulation within the Commission's scope, but it's a population that uses very expensive services, as the Chief Justice said, often without significantly different outcomes. Next slide, please. About a year ago, we had the opportunity to present to the Mental Health Courts and Corrections Subcommittee on work underway in Georgia focused on familiar faces. At that point, we were able to share some data that Fulton County had put together based on data from their detention center, from the Atlanta Police Department, from emergency departments. We were also able to share emergent practices in a number of non-Atlanta places, including Forsyth County, Chatham County, and at that point, the Mental Health Courts and Corrections Subcommittee made a recommendation to this commission in last year's report, recommending the establishment of a statewide advisory committee to further investigate familiar faces and identify policy strategies that would support better care for this population. That recommendation was picked up in HB 1013 and passed and has been the groundwork for the work that we're about to share with you today. Since then, the Georgia Criminal Justice Coordinating Council has released findings from their own Familiar Faces study, and we're happy to provide that full study. I will try not to do violence to the findings presented by Stephanie Lopez Howard, who is the researcher. We wanted to share a couple of highlights for you. So the team at the CJCC were able to look at jail admissions from 9 Georgia counties, 3 rural, 3 suburban, and 3 urban, over the course of 5 years. They looked at the top 1% of bookings, and they called those familiar faces. And you see on the slide the number of people involved, 2,000 some odd. Total familiar faces, about 650 of those familiar faces who were charged with felonies also had a mental health record at the Department of Corrections. So those were able to be identified as familiar faces with mental illnesses. I'd like to draw your attention to the cells that are in yellow, where you see that for the familiar faces with mental illnesses, they had on average 51 jail bookings. If you can imagine what life is like entering jail 51 times. They had we call it a survival rate or an average tenure in the community of 172 days. So that's 172 days from being released to being arrested again. And again, it gives you a picture of what life is like for these people who are sort of moving in and out of the criminal justice system quite a lot. And the frustration for them, their families, as well as obviously law enforcement and the courts who are seeing the same person in front of them over and over again. And these trends held against in the different types of counties. There were some differences in urban, rural, and suburban that the advisory committee has had a chance to look at, and those also inform the recommendations. Next slide, please. So following the passage of HB 1013, the Familiar Faces Advisory Committee was convened this spring as part of the Mental Health Courts and Corrections subcommittee of this commission. The subcommittee members were invited to join the advisory committee. We also expanded membership. If you can give me the next slide, please. So that we had a really robust group representing leadership from all three branches of state government, Chief Justice Boggs, Senator Strickland, as well as Kristen Long from the governor's office. We had a number of judges and law enforcement stakeholders from diverse counties. We had ACCG and the Georgia Sheriff's Association represented, as well as the Georgia Mental Health Consumers Network, as well as several representatives from county teams that are doing work on familiar faces. So these are the folks who are on the ground trying to put these programs together, again, in different counties. So the advisory group has been meeting regularly to hear from local counties about what their programs look like, what challenges they've heard, and where they see opportunities for improving outcomes through state policy. Next slide, please. We also were able to work with 10 counties from around Georgia, and you're seeing the map here, who put up their hands and said, this is something we're working on. We want to learn from other counties on what they're doing, and we're also willing to share what we're doing with the State Advisory Committee so that if there are practices that are working well in Troup County, those can potentially be expanded to other counties around the state. So this group includes justice, health, stakeholders, as well as people with lived experience from a diverse set of counties who've been helping us identify areas for policy recommendations and then also hone the policy recommendations to make sure that they're practical and feasible for diverse counties within the state. Next slide, please. As the Chief Justice said, we've arranged the recommendations into these 4 areas to support work for familiar faces. 1, increasing the capacity to identify familiar faces. 2nd, improving how the criminal justice system responds, including more robust pathways to community-based care. 3rd, expanding access to community services, and that includes not just treatment, but housing, which is something that we heard very strongly as a need for this population. And finally, supporting knowledge sharing across the different counties and stakeholders so that we don't have people reinventing the wheel. We're really positioning different policymakers to take advantage of the lessons learned from other counties. And I would just want to note my colleague Marilyn Leak, an Augusta native, has been our the senior policy analyst leading this work. And now I'm going to turn it over to our project manager, Amy Button, to walk through the policy recommendations in the first couple of areas. Thank you.
Thank you very much, Hallie, and thank you to the chair and commission members and Chief Justice Boggs for the opportunity to present on behalf of the advisory committee about the work that they've done and their recommendations. Can you go to the next slide? These recommendations are in the first category, bolstering local capacity to identify people with high utilization across systems, familiar faces. The first recommendation has to do with creating and disseminating statewide guidance to standardize information sharing forums developed by appropriate state partners, such as the Attorney General's office, administrative office of the court, state and local judges. So it really looks at, for example, developing a model definition of mental illness that could be shared across all state agencies to standardize how it's measured, guidance on interbranch information sharing, very much in line with recommendations that we expect we will hear from the workforce subcommittee, and developing model forms that organizations and systems locally can choose to use when it makes sense in their community. So that's things like memoranda of understanding, business associates agreement, data use agreements, and especially a universal consent form, because that's such a sticky wicket for sharing information in many cases. Secondly, it talks about supporting several communities, jails in several communities that want to implement the use of standardized forms, and provide some resources so that they can do that and the rest of the state can learn from their experience and hopefully scale it up. The second recommendation is about supporting several communities. The second one is about mental health screening in jails. So providing funding to a small number of local jails to implement validated behavioral health screening and validated housing stability screening. I apologize for my heater in the background. So anyway, implementing validated screening in jails, providing funding in order to support that with training, model forms, and guidance. And aligning with the interest of the Georgia Sheriff's Association and local sheriffs around the state to advance best practices in validated screening within jail credentialing and practice standards. And so that pretty much wraps up the recommendations related to local capacity to identify familiar faces. The next has to do with improving community response. Next slide, please. The first policy generally has to do with access to crisis and other resources. So funding a small number again of local community-based communities or regions that want to have a dedicated coordinator position that can build collaboration locally between criminal justice and behavioral health partners. This is a role that would be working directly with co-responder protocol committees established under SB 403. So that's really working out some of those agreements, understanding and collaboration across organizations and jurisdictions, and in some cases across counties. Secondly, provide support for DBHDD to analyze the need for non-crisis beds for familiar faces. People may be really struggling, but it may not be appropriate or needed to be in the hospital or in a crisis center. So maybe create short-term housing and diversion options or psychiatric respite centers. The second item in this area is reducing wait times for state hospital beds and competency evaluation restoration services. This recommendation looks to appoint a task force to look at revisions to forensic code related to outpatient restoration for misdemeanors. That would be likely with the advice and counsel of superior court judges, community providers, DBHDD, forensic staff, people with lived experience, and other stakeholders and subject matter experts. So that wraps up the recommendations to support timely and effective community responses. I am going to pass it now to my colleague, Charlie Francis.
Thanks so much, Amy. Yes, my name is Charlie Francis, Deputy Program Director for Housing at the Justice Center, and I'm going to introduce policy area number 3. Like we said before, the first couple policy areas were about really identifying familiar faces and making sure that crisis systems were really in place to be able to respond effectively. But now, if you think back to how we define this population, familiar faces are folks who are really caught up in a vicious, cycle between crisis systems as well, jails, ERs, and shelters. And what we really need to do is ultimately to put the community supports in place to really lead to better outcomes and help break this cycle. So that's what this policy area 3 is really about. There's a particular focus on housing, but also really connecting people with other supports that they need, including access to benefits, access to healthcare, and a number of other things. Next slide, please. So our first recommendation here is to expand jail and reach services in Georgia. Throughout our development process, this is something we heard loud and clear from stakeholders at all levels, all across the state, really bringing services to people where they're at. And we still have 2 action items here. And we really, as with some of our other recommendations, we really want to focus on building local capacity, looking at counties who either have a promising program that they want to expand or a good idea that they want to create, giving them the resources to connect with people while they're still in jail, to do that and to connect people with housing resources, with Medicaid benefits, with access to public benefits. And, doing that on a competitive basis through funding and technical assistance. And our other action item here is increasing funding for the SOAR pilot program, which really focuses in on connecting people with SSI and SSDI benefits. This is a national best practice that has been implemented really successfully in Georgia. It has one of the highest success rates in the country. And another thing we're recommending is just really increasing funding and support for this program as well. Next slide. So in addition to InReach, that connective tissue to get people connected with supports, we have a number of recommendations here focused on increasing access and availability of housing. Not the least of which, not only because we've heard this loud and clear across the state, but also because, research and practice have shown time and time again that providing safe, stable, affordable housing is one of the most effective things you can do for this population. And so these recommendations really also look at a couple of different time horizons, because when you're looking at housing, you have to meet a couple of different needs. People have immediate needs to be connected with housing right now. But also the thing about affordable housing, and probably most of you know this, is that there's never enough of it. So while you're working on meeting these immediate needs, you also need to be looking at the medium and the long term to be growing the pie and increasing the supply of housing. So the first action item here is to issue guidance to housing providers funding by the Department of Community Affairs to revise their tenant selection plans, to really focus on reducing criminal record related barriers to housing. So that's just looking at their screening criteria. So reducing, say, the number, reducing the number of years they might look back for certain offenses, maybe focusing less on nonviolent offenses. There's a number of different ways you can go with this, but it's really in keeping with current HUD guidance as well as the state housing finance agencies in a number of states have issued some similar memos to providers they fund, including in North Carolina and Louisiana. So there's a lot of precedent for this, and it's a pretty immediately impactful move. You know, a second sort of short-term move is looking at existing housing programs. You know, there's never enough money for housing, but right now we do have somewhat more resources than usual, and particularly because of the American Rescue Plan. So looking at what housing programs we have now, such as Home ARP and the Housing Choice Voucher Program within DCA in particular, and seeing what set-asides can be made for this population. And just a note about DCA as well, too. We've talked with them quite a bit about these recommendations. They're a very willing partner, and there's a lot of willingness at the leadership level to really serve this population. And a lot of this would not require legislation. And sort of the third recommendation here, you know, is a bit more of a medium to long-term recommendation, but it's looking at the low income housing tax credit program, which is, you know, the largest tool that we have in Georgia and nationwide for financing the creation of new affordable housing. And how those tax credits are given out to developers each year is governed through a document called the Qualified Allocation Plan. So working with DCA to increase incentives to develop more supportive housing through that allocation plan. For example, increasing the number of credits allocated through a supportive housing set aside. And that's a strategy that has also been implemented by a number of other states. And then finally, you know, in addition to larger housing providers or those funded by an agency such as DCA, you know, we have a much larger universe of landlords out there, you know, whether corporate landlords or mom and pop landlords, which still represent, you know, the majority of the housing inventory in any given community. And so there are really incentives needed to get more landlords to rent to this population. You know, there's a lot of discrimination and stigma out there, policies that, you know, provide barriers to people with criminal records, and also rents are going up. So incentives are needed. Landlord incentive funds in general are a growing national best practice, both for people with justice involvement and vulnerable populations in general. And so we're recommending seeding a landlord incentive fund, starting with federal funding and then matching with private funds, you know, for example, from health plans, which are really starting to get involved in this space, and allocated on a regional basis to really focus on landlord recruitment. Incentives such as leasing incentive payments, so a payment at lease up and for retention, and what's called a risk mitigation fund. So being able to make almost an insurance claim in case someone leaves their apartment early in the event of damages, etc. So a whole suite of housing recommendations here that we really feel would be very impactful for this population. And now I'll pass it back to Amy for the remainder of policy area 3.
Thank you, Charlie. So the last two recommendations that relate to expanding access to community-based services and supports. First one is workforce shortages. We heard from every stakeholder in every part of the state, every system and all organizations, how severe and pressing the workforce shortages, how impactful it is for keeping programs open or beginning programs. The advisory committee endorses the recommendations around workforce of the Workforce and Systems Development Subcommittee, and in particular notes the priority of finding consistency in credentialing standards for managed care organizations in Georgia. The last recommendation in this section has to do with strengthening Georgia's peer support specialist capacity. Georgia has a uniquely strong peer presence and large and capable and very mature peer community. You know, it's a very, very strong presence in the state. The recommendation asks for adding peer members to the Behavioral Health Innovation and Reform Commission and authorizing the commission to lead a comprehensive planning process to expand the number of forensic peer support specialists, which will be extremely impactful There are a small number of peer support specialists in the state. And it's an area where there can be enormous impact for improving connectivity after release and generally just really shoring up the system that serves familiar faces. And that wraps up policy area 3. I'm going to pass it back to Hallie.
No, thank you, Amy. The final area is really creating the infrastructure for the counties that are doing this work to continue doing this work. Our team has been able to support the Familiar Faces work this year and looking into next year through support from Arnold Ventures, but there is a strong interest among Georgia counties in continuing to learn from each other and benefit from external subject matter expertise. If I can have the next slide, please. For example, the study of Miami-Dade that the Chief Justice referred to was possible through a partnership between the Florida Mental Health Institute at the University of South Florida and Miami-Dade County, where the university was able to work with the county to develop a methodology for identifying familiar faces, support the data collection and analysis, so that they're really able to put concrete numbers on their familiar faces population. This recommendation is to look at opportunities within Georgia to build capacity to continue support for county coordination with each other, like we saw in our county peer-to-peer meetings. The counties who were participating shared information with each other, from processes for doing things to how they're negotiating with different IT vendors to make sure that they're getting what they want. I'll also say this was the first time I've seen a group of people plan a barbecue in the chat during a stakeholder engagement meeting, but there was just a lot of interest in learning from each other and working together that it would be a loss not to continue to foster. And we know that there are a number of universities in Georgia that might be able to continue to support this work, whether it's the coordination, whether it's specific advisements on information sharing or data collection. This issue will not be solved with this set of recommendations in the next 12 months. And it is critical from the perspective of the advisory committee to ensure that there are tracks laid out to continue this work. That is the end of our presentation. Again, thank you for having us. I will turn it back to Chief Justice Boggs.
Thank you, Amy. Happy to answer questions, Mr. Chairman, if there are any. As you can tell from the recommendations, some have budgetary impacts. We're not entirely sure what that impact would be for some of the recommendations. Some are regulatory, some going to require some legislation, some are not. But I do appreciate the thoughtful approach that the Justice Center has brought to the conversation, and that really first and foremost, we need to identify this population more readily and more appropriately. And so thinking about how we've stratified our recommendations to really first identify, then improve the response, and then expand access to care, it implicates a lot of the things that the larger commission is engaged in, and then finishing up with questions about information sharing. So I hope you all found that helpful, and happy to answer questions if there are any.
And have one. The first one is from our chair of the Workforce and System Development Subcommittee, Representative Oliver.
Thank you, Justice Boggs. I'm very interested in your recommendations in relation to supportive housing. Is it accurate, or could I be hopeful that there will be federal money involved in that, and availability or coordination with existing funds existing today, and the leadership for going to get that federal money? Would it be with Christopher Nunn or AOC?
Yeah, I don't know the answer to the question, Madam Chair. I simply don't know the availability of federal funding and where that leverage and that lever is. Of course, I think it's imperative that we leverage whatever federal funding is available to the extent the strings are not too onerous. Central to this population, and really to a larger population that is impacted by the Mental Health Courts and Corrections Subcommittee is the issue of housing. And we looked at it for 8 years during criminal justice reform and weren't able to really wrap our arms around it with any meaningful change. We do see some communities across the state that are doing some good things, and that question might more properly be posed to some of them that are leveraging some, I think, of federal grant funds.
I think the homeless money is almost all federal money.
Yeah.
And that covers, I was listening to what he was talking about, some of the federals. I'm interested in some.
Charles may know. I mean, we can ask him. Haley, if Charles is still available, does he know an answer to that question?
Yeah, I'm happy to chime in, Chief Justice. Most that is correct. Most of that money is federal money. In particular the ARP money. When we're talking about, as well as the tax credit money. Both of those two recommendations are actually indeed heavily focused on really looking at those increasingly available federal resources and making sure that more of them are really directed towards the benefit of this population. So absolutely that will be a focus.
And we just got to find somebody in OPB or somewhere to go after that money.
Agreed.
Thank you.
Thank you for the question.
I think our Child and Adolescent Subcommittee Chair, Dr. Eric Lukowich, has a question.
So I was really impressed by the information you shared with us about familiar faces, but that brought to mind a question about how many of the people identified as familiar faces actually have children, and what happens to them in that situation.
Yeah, I mean, I think we know from mainly anecdotal stories, but we know that many of these children are in foster care, or at least they're being raised by children, by kin that are avoiding the implications to the foster care system. I don't know the number, and I could tell you that some of the communities that are already engaging in some very thoughtful local efforts to remediate the problem could probably answer that question because they know. As a judge, I can tell you many of the people that are engaged in the criminal justice system have children. And many of those children are left without a parent at home, at least one, if somebody goes to prison. And so ultimately, it implicates a broader set of concerns, right? It implicates the education system. My wife's a school teacher. I deal with, she has many kids that don't have a single parent at home, much less two. So obviously, when we start looking at the problem, the tentacles of a behavioral health issue and implications to the criminal justice system are far broader than just on that individual that the system is dealing with. And the children that are caught up in that system are oftentimes not talked about regularly, but the impact on them is significant. So thank you for raising the question. And the answer is, we need better data. And as these data are mined and unsiloed, if you will, I think we'll find that better informs our recommendations moving forward.
Thank you very much. That's a great answer.
Are there any other questions? All right. Justice Boggs, anything else in closing? All right. Thank you very much. Very informative. And thank you for all the work your subcommittee and the other partners you've engaged have done on this issue over the past 12 months. All right. Next is Dr. Brenda Fitzgerald, who chairs our hospital and short-term care facilities and access subcommittee, and she's going to be presenting online today. Dr. Fitzgerald.
Thank you so much. It's so good to see all of you. Wish I were there with you. We had a lot of testimony during these past few months. We heard from people with special needs as far as access to healthcare, to mental health care, from older adults, from farmers, from rural hospitals, immigrants and refugees, and access also in the early education setting. Some of the things that really struck us, one, when we heard the testimony from Department of Juvenile Justice, they told us that in their youth development campuses, 72.3% of the children in those lodged on those campuses need behavioral health care. They told us that in the regional youth centers, 49% need behavioral health care. The national statistics are those involved with the Department of Juvenile Justice, 70% of them need care, behavioral health care. But they said that they had a lot of difficulty in a couple of things. One, coordinating care, and two, when they tried to get children admitted to the psychiatric regional centers, they were denied admission simply because those children were in detention. So you have children with high needs and difficulty getting them placed. The second bit of information that was really impactful to us, Resilient Georgia paid for a study to be done looking at Amerigroup, all their interactions in the years 2019 and 2020, so 2 whole years of data. And that basically is the foster care population. And for the foster care population, 13% of them needed behavioral health care. And again, the real problem was in difficulty of coordination of care. So we know that maybe a little over 15% of Georgians do not have behavioral health insurance, do not have insurance that covers their behavioral health needs. So our question was, one, how about those that do? Are they getting the help they need? Two, how difficult is it to get into existing hospitals and treatment facilities? And three, once we answer those questions, then we need to make a recommendation for where and how we should expand the rooms that we have. So we think that there are 3 people that will present that give some insight to the whole committee on these questions. And the first one is from the Atlanta Regional Collaborative for Health Improvement, ARCHI. And we have 2 presenters, Carrie Oliver and Aviva Berman, and they're going to talk about really and truly the Atlanta needs. Now, this is not statewide information, but it is extremely good Atlanta information. So if you will proceed.
Thank you, Dr. Fitzgerald. Good afternoon, everyone. My name is Carrie Oliver. As Dr. Fitzgerald mentioned, I'm from the Atlanta Regional Collaborative for Health Improvement, or also known as ARCHI. And I believe Aviva is going to share our slides, and we're going to share a little of the information. So we had the opportunity to present to the committee back in February of this year. Since then, of course, the Atlanta healthcare landscape has changed. And so we've been able to also note how some of these issues that we noticed in February may have grown larger, have additional needs as time has progressed. Next slide, please. So ARCHI convenes the care coordination teams across 6 Metro Atlanta health systems, including Grady, Wellstar, Emory, Northside, Piedmont, and St. Joseph's health systems. This call originally started within COVID in order to navigate that landscape as it's changed, but over time, it has grown into an opportunity for health systems to identify some emerging issues that they're seeing within their hospital emergency rooms, as well as identify ways that they can connect those patients to community services in an effective way. So overall, within the progression of that call, what we did notice is that many of the health systems began to speak to an issue that they were having specifically in regards to patients with complex needs. So those could be individuals with developmental or intellectual disabilities, physical disabilities, or behavioral health challenges. And what they were seeing was that they were seeing an influx of those patients into those hospital systems and having extended care without an actual medical need. So when we looked at that issue on a broader scale, we thought about how could this impact the health systems or just healthcare overall. What we noticed was oftentimes because these patients have multiple diagnoses or multiple challenges that they needed to address, they often was no system or one place to put them that would take responsibility. And because of that, they would have these overextended stays within the healthcare setting, more specifically within emergency departments. And Aviva will speak a little bit later into what that looks like from the patient's perspective. We also noticed that this was a systemic issue. So it's not just something that we could put a small Band-Aid on, but it highlighted larger issues in regards to navigation, assessments, and eligibility requirements across the health systems as a whole. Of course, these issues do not happen in a vacuum. So these happen in the midst of the beginning of the COVID-19 pandemic, and most recently with our hospital closures in the Metro Atlanta area. These also highlighted larger issues in regards to workforce shortages and just a limited supply of services and supports across the healthcare setting. On a larger scale, we also noticed that these issues would have a macro influence on the time as well as the resources that health systems had to treat other patients, as well as these patients that were often in these medical settings then could not get the support they needed for their immediate needs, and then would often threaten their long-term health and safety across the state or even across the metro Atlanta area. Next slide, please. So we wanted to dig a little deeper into this issue. Overall, Archie has an invert the burden strategy, which aims to invert the burden of navigation away from patients and families that are seeking support, and instead hold systems accountable to remove silos and to create more coordinated systems of care. So when we dug a little bit deeper into this issue and what it looked like on the root level, what we found that what we saw were these extended stays, but they were indicators of much larger issues. So that administrative burden that healthcare coordination teams then have to navigate these systems or create workarounds to discharge these patients with complex need. We also noticed that there was limited support in the community setting and in the hospital setting for those individuals. Even larger than that, those that had those larger stays, as I mentioned earlier, often had an influx into these emergency settings. So that's an increase in patients and families coming to these emergency care departments to meet a need that had much larger support. Next slide, please. So I'll pass it over to Aviva so she can speak a little bit more about some of the case study and anecdotes we were able to gather from the hospital systems, as well as speak a little bit to some proposed solutions that we gathered.
Thank you, Carrie, and thank you all for your time and energy here. As Carrie mentioned, we convene our health systems on a biweekly basis to discuss care coordination, specifically within the complex patient population that they see on a regular basis. So we've asked them to contribute some stories, case studies, common themes across the health system so that we can better understand what's going on at the city and state level. I'm not going to go line by line with these case studies. We will distribute this deck at a later time so you can kind of dive in, but they're very familiar and they occur on a frequent basis across our health systems. Oftentimes, these patients come in with severe diagnoses with no caregiver or an ill-equipped caregiver, and they stay in the hospital, either in the ER or they're inappropriately admitted for weeks and months because there are very few resources in the community to discharge them back into. These hospitals are feeling challenged in that they are unable to discharge the patient in a safe, timely, and efficient manner. And you know, these are just 4 stories, but we hear about these types of stories and patients on a regular basis on our calls. And this kind of adds the humanity and illuminates the kinds of crises and challenges not only are the patients are seeing, but the staff as well. Case study themes across these patient stories, that there's a lack of service availability required, and that extends into an unnecessary hospitalization. There's a limited capacity of crisis beds in the community, and there are challenges with accessing respite services and care. Lack of appropriate services and staff with appropriate skills and training can leave the patient without support. Housing provider staff lack training in trauma and behavioral health disorders. Many complex patients need a support person or case manager to help them navigate this system and to stay in the services, not just after enrollment. We need more wraparound services. Intake procedures do not fit patient circumstances and thus delays care. Requires guardians, though patients in hospital care do not always have a guardian or caregiver. There are multi-step processes, and they're difficult to complete for individuals visiting the ER, even if doing so frequently. We need stronger coordination with hospitals for waivers, including waiver application process and easily knowing which patients are enrolled in which waiver program. So these themes are seen across our hospital systems, our partner systems, and has helped us inform what policies and asks that we have for this commission and other leadership in the state. So with that, we have some proposed solutions, some short-term, some middle, medium, and long-term for future asks. For short-term, we encourage you all to increase the base salaries of employees working for DBHDD, those that serve the BHID and DD population, to keep up with inflation, suggested a 10% increase. Please consider completing the rate study specified in HB 1013 to enhance payment to core providers to enable sustainability, recruitment, and retention, and to continue to backfill previously closed beds that are designated for developmental disabilities and/or skilled nursing patients at Georgia Regional in Atlanta. We know that beds are continuously being reopened, and we thank you for that support, but we ask for continuous backfill. So medium and long-term asks and solutions to consider increased funding to fully staff ACT and/or crisis support teams. These teams are not fully staffed, and for a myriad of reasons. We all know that workforce is a challenge across the board, but these teams suffer those challenges as well. So if there's increased funding, they can complete their teams to better serve these patients and populations in the communities. And we asked specifically for Fulton and DeKalb counties. Please complete a workforce study to determine appropriate DBHED staffing and service levels so that we can better understand what's needed and where and for what population. And then lastly, the biggest ask and most long-term ask is to please allocate funding for an additional 150 crisis beds throughout the Metro Atlanta area in the 2023 budget. This can include funding for the Fulton County Behavioral Health Crisis Center, which will have those crisis and respite beds and services as well. That can count towards the 150. Archie, alongside our hospital health system partners, presented to the hospital and short-term care subcommittee back in February, and we were asked by this subcommittee, what do we need? What can they do for us? And after surveying the health systems, the number 150 for crisis beds, infrastructure, and associated staff was decided upon. Looking ahead, we continue to convene our health systems and DBHCD leadership for greater collaboration and problem solving, both on a biweekly and a monthly basis, depending on the need and the collaborator and partner. And we ask that you stay in touch. Here's our contact information. If you have follow-up questions that can't be resolved today, if you want to join our biweekly call with these care coordination partners, we invite you to do so as a guest. So please stay in touch, and we thank you for your time.
Thank you very much. And again, let me emphasize that these folks have been working together for a long time, so they have a real sense of how many crisis stabilization beds, and we asked them to go back and help us determine how many crisis stabilization, but this is just Atlanta. That does not mean that we have numbers for other parts of the state at this time, and we certainly need crisis stabilization beds throughout the state. Let me also say that this really elicited this whole business of how we get patients in hospitals. We had some monies available to us, and we asked Georgia State University to say, is there any state that has solved this problem, that has a really efficient way of tracking where patients are admitted, and a tracking system for these either stabilization beds or inpatient beds? And the answer to us is nobody does. Only 9 states, and Georgia's one of those, has really a tracking system that is more than, there's 17 states that will say how many beds are available, but Georgia is one of the 9 states that has a little more sophisticated approach to it. We think that's good. We think that means we have a little bit of a head start, but we do not think that the current tracking system is doing as good a job as it needs to do. Our recommendations are that we absolutely track on everybody that comes across the GCAL board, the time from when they are first entered into the system to when they actually get placed. So we have more than these simple stories. We have a real number throughout the state. 2, if a patient is refused admission to a particular facility, we need to know why. Not in a punitive sense, but simply we need to know why. For example, DJJ telling us that if a child's in detention, they can't be admitted in certain places, they're turned down. We need to know that so that we have an idea of not only the crisis stabilization beds we need, but those that have particularly high requirements. And third, as we heard from at least the first time we looked at some of these residential facilities, 60% of the people were in out of state, and we absolutely need to monitor that. How many of these beds are out of state patients, and how many people are inpatient states, are in-state patients? So the next thing we want to talk to you about is those people that have health insurance. And we talked about it's huge what was done with parity last year. That's fabulous. And we looked at but we want to look at the insurance plans that we had, network adequacy. So we heard testimony from advocates. We heard testimony from the insurance companies. And we were particularly impressed with the presentation of Dr. Jane Zhu. She is an assistant professor of medicine at Oregon Health and Sciences University. And if you will give us some information sort of on the statewide objective on how you look at a network and say, is this network adequate?
Thank you, Dr. Fitzgerald. Let me share my screen. Please let me know if this works. Okay. Let me. All right. Thank you, Dr. Fitzgerald, again, and good afternoon. Thank you to the chairman and commission members. And as I said, or as Dr. Fitzgerald said, I'm not from Georgia, and though I sort of wish I were because of all the amazing work that you are doing in this commission, I am deeply appreciative of that. I'm a health services researcher and a primary care physician focused on mental health access and network adequacy. So I'll be talking more generally about where the state of this science is and recommendations of how to improve network adequacy in mental health services. So we'll be talking about 3 different topics today and briefly overviewing why mental health networks are inadequate, what are existing network adequacy standards and challenges, and considerations for monitoring and assessing network adequacy in mental health. So we all know here that we're facing a critical national workforce shortage, and the majority of U.S. counties, including in Georgia, have been designated as mental health professional shortage areas. And so what that means is that this crisis in workforce, it has exacerbated a scenario in which access to coverage does not equal access to care. The mental health professionals who patients are ultimately able to see represent just a small fraction of the total workforce. And this elevates the role of provider networks, essentially, provider network design, capacity, availability. These are the sets of providers and facilities that deliver health services to plan enrollees. And essentially, they serve as the intermediary between who's out there and who patients can see. So who's accepting insurance, then who's considered in network and contracted for specific plans, who's actively seeing patients, and ultimately who's available and accessible. Provider networks thus are a key link between coverage and access, and they increasingly are a tool that are used by managed care plans to manage costs because in-network and out-of-network providers are subject to different cost-sharing arrangements. And over time, provider networks have gotten narrower, covering fewer providers in a given area. This has been particularly concerning in mental health services, where on average, 1 out of 11 available providers in a given state participate in any mental health network. We know that some of the reasons for these narrow networks are on the provider side. About half of psychiatrists accept any form of insurance, which is a much lower proportion than compared to nearly every other medical specialty or surgical specialty. And there's a couple of key drivers that persistently sort of motivate these low rates of insurance acceptance. One is reimbursement disparities. In Georgia, for example, mental health professionals received about 37% lower payments than other medical and surgical providers for the exact same billing codes. There are billing delays, as well as credentialing and administrative barriers to participating in a network, as well as clinical complexity and acuity, with psychiatrists accepting insurance, who accept insurance, seeing more serious mental illness, but being able to spend less time with patients. And all of these serve as disincentives for participation. On the insurer side, there are certain pros and cons to having broader versus narrow networks. Broader networks may provide more choice and expand access. And in Georgia, as well as other states, there's a form of an any willing provider law, which requires insurers to accept any provider in their health plan network if they meet some specified criteria. These laws may reduce insurers' negotiating power to lower costs with providers. And on the other side, the benefits of narrow networks might be to direct patients to high-value hospitals or facilities that are known to be high-performing or high quality. It may give insurers bargaining power against providers to lower costs. And on average, narrow networks are seen to have better financial performance. But there are effects on healthcare spending, including reducing including generating health hassle costs that reduce the quantities of service, and they're associated with lower premiums on the order of 6 to 16% cheaper on average. On patients, narrow networks or networks that are too narrow may be associated with higher network use and out-of-pocket costs. In Georgia, adults and children are 9 to 10 times more likely to receive outpatient mental health care out of network versus for primary care services. There's evidence in the empirical literature that narrow networks limit access to high-quality providers, that they reduce healthcare utilization, and they create potential treatment delays, particularly for mental health services. So the concern here is that mental health provider networks are essentially a tool that can be used against parity, or they can be used as a tool for parity. In 2022, the Mental Health Parity and Addiction Equity Act report to Congress showed that health plans are really failing to deliver parity for mental health and substance use disorder benefits, despite parity legislation. And one reason for this is that provider networks may be contributing. They are often overlooked and understudied, and often not subject to much regulation as it currently stands. So in this context, network adequacy is easy to conceptualize, but difficult to operationalize. This is a health plan's ability to deliver reasonable, timely access to sufficient numbers and types of in-network providers. But as you can see, what constitutes reasonable access, timely access, and sufficient numbers is up to an open interpretation. So states have essentially used a range of network adequacy standards. They vary across types of coverage, but they've coalesced around similar considerations. So the chief questions being, how far away are providers located, measured with travel time and distance? How long are enrollees waiting to get appointments, timely access or wait times? How many providers can patients select from, or provider choice? And are there enough providers to serve enrollees' needs, measured by provider to enrollee ratio or minimum number of providers? Across marketplaces, network adequacy standards range from more flexible, as in Medicaid managed care, to more stringent, as in Medicare Advantage. For example, in Medicare Advantage, plans must abide by specific standards for 27 provider and 11 facility types, among them individual psychiatrists and inpatient psychiatric facilities. Whereas in Medicaid managed care, any quantitative standard is valid, and that creates more flexibility. However, I will say that there are, on paper, more federal protections in Medicaid managed care. For example, enrollees who do not have access to adequate networks are permitted to leave their plans, and there are other protections in that manner that are not available in, for example, the ACA marketplaces. Complicating this picture is challenges with provider directories, their network adequacy is generally assessed using information provided by insurers to regulators, and insurers may overstate the true extent of their networks, whether just because of capacity, or it may be done through different means because of information deficiencies. For example, basic information is often inaccurate. Estimates are about 50 to 70% of records are inaccurate in provider directories. Up to 2/3 of psychiatrists listed in health plans see few or no Medicaid patients a year, and there a huge prevalence of ghost networks. And care is highly concentrated with psychiatrists and other mental health providers participating in multiple plans, multiple markets, which makes it very difficult to track who's actually seeing patients and who's available to which members. So other than problematic data input, network design is complex. There are often trade-offs between network breadth, costs, and that is very difficult to capture using one-dimensional measures like travel time or distance or provider to enrollee ratios. Network adequacy measures are often designed to just pass a test. And in fact, most health plans pass network adequacy measures because they're not formulated around an objective standard for access to care. There's little to no enforcement mechanisms, and there are untested, still untested are the incorporation of new models of care delivery, including telemedicine and integrated behavioral health and primary care into network adequacy standards. And so here are some, we're going to talk a little bit about considerations. Right now, there is a lot of variation in network adequacy standards in, for example, Medicaid managed care. Amongst the 39 states that we looked at here, most use time and distance standards, fewer define these for mental health specifically, even fewer for substance use disorder treatment, and virtually, just a handful of states had any sort of monitoring enforcement plan. So lots of variation here. And there are lots of differences across states and markets. Georgia is one of those states that in Medicaid managed care uses time and distance standards and appointment wait times to assess network adequacy across a number of important specialty categories. But as you see here, the same standards are not applied for qualified health plans in the ACA marketplaces. This is not the case in other states. Let me give you a couple examples of case studies that could be useful. In New Mexico, the current regulations are that ACA qualified health plan regulations are now aligned with those in Medicaid. There are new standards of essential community provider inclusion that surpass minimal federal requirements. And there are new established cultural competency requirements for their providers that are considered in network. In New Hampshire, they use all payer claims data to actually measure provider participation in health plans across all markets. And that helps insurers to identify non-contracted providers who are actually providing particular services. They also categorize providers that are based on key covered services rather than specialties, knowing that different providers serve similar roles depending on what type of care is being delivered. And they developed public and interactive consumer-facing tools that help consumers use network breadth in order to improve their decision-making. So the landscape of current and proposed standards are going to change. They are becoming more stringent over time. In Medicaid managed care, there is a mandated readiness review of MCOs prior to contracting and enforcement. There are new considerations for cultural and linguistic competencies. And the current regulation of using any quantitative standard to measure network adequacy is now going to under review, and Medicaid is looking at a comprehensive access standard, which is currently undergoing public comment. In Medicare Advantage and in ACA qualified health plans, there will, especially in ACA, this is new for, there are going to be mandated time and distance standards across a defined list of provider and specialty types, mandated timely access standards, geographic and urban distinctions in terms of their network adequacy criteria, measurement of telehealth availability, and the impact of that on network adequacy, requirements for inclusion of essential health providers, and greater oversight and enforcement of provider directory accuracy. And so considerations as we move towards understanding network adequacy and improving that. One is a trade-off between on network breadth that requires weighing the balance between access to care and allowing competition to keep prices and spending low. The second decision trade-off is on specific network adequacy standards, and that requires weighing between ensuring flexibility to meet community needs and enforcing accountability to protect consumers who are faced with out-of-network care. So potential levers to improve network adequacy for mental health include a number of buckets. One is enhancing data transparency and collection. So that includes standardizing provider reporting and verification, strengthening capacity and systems for data collection, more consumer-facing data transparency tools to assist with data decision-making, measuring what consumers actually face rather than what is theoretically available. So that means incorporating multiple sources of information through patient surveys, claims data, as well as provider directories. In identifying providers who actively see patients, the key about claims is that it's verifiable and objective. And so, for example, a provider directory listed provider who doesn't see any patients should, maybe ought not to be listed as an in-network provider. Consider different types of mental health providers and facilities and the specific services they provide. Facilitate a consumer complaint intake system so that access issues are identified and targeted. The third bucket is enforcement and consumer protections, including greater oversight of provider networks before marketing these networks to consumers, auditing and enforcing accurate provider directories, aligning regulations across markets, enforcing corrective action and penalties, and then implementing consumer protections to cover out-of-pocket, out-of-network care when that's needed. And finally, longer term asks include a number of bigger picture levers that will build network capacity and participation in the long run, things that other subcommittees are working on as well, addressing reimbursement administrative burdens, workforce pipeline, scope of practice laws. And in particular, with respect to network adequacy, really trying to understand and measure the effects of telemedicine and expanding collaborative care models as they relate to access to mental health services, with special attention to rural frontier areas that are currently in provider deserts. So I'll stop there and thank you again for your time.
Thank you so much. We really appreciate that overview. We know that Regina Quick, who is here in the audience, has been working on some legislation for network adequacy. Our recommendations for the committee are we definitely need to get our definition in this year for network adequacy. South Carolina has laws that all plans are subject to requirements, and Georgia does not. And Florida does have some, Alabama has some, Tennessee has some, but Georgia is one of the states that does not. Georgia really needs to do this. Our thinking so far is that we really need to emphasize time to appointment. We have looked at that will be a federal requirement in, I think it's 3 years, but the sooner we can do that, I think the more accurate we can get as far as networks is concerned. Second, we need to really make sure that our telehealth laws, as you heard from Dr. Leibowitz, are solidified. The testimony we heard from one large group that was a private group is that they see 60% of their appointments by telehealth. We need to make sure that these are included in network adequacy. 2, the out-of-network ratio, the ratio of the number of patients to the number seen, and also who's taking new patients. We think these absolutely should be included in the legislation that we pass this year. So then we looked at the third thing we're going to talk about today is we looked at what about waivers? What can we do to Medicaid so that what waivers can we get so that we make sure that we have adequate coverage? For those of you who may not know, Medicaid does not allow routine payment for adults for either substance abuse or mental health issues, which means that the states need to apply for a waiver so that Medicaid can be used for these monies. If you look at payment exclusion for substance abuse, 39 states already have it or have it pending. If you look at payment exclusions for mental health, 16 states already have it. Or it's pending, including Alabama. The other thing waivers we were interested in is we need to make sure in Georgia, if you are on traditional Medicaid, you can go to the residential treatment facilities, but you cannot be admitted to a larger psychiatric hospital, is what we understand. This is, I think, an oversight that really needs to be corrected immediately. The other ones we are interested in are the behavioral health community benefits. That's in 31 states. And in Florida, there's a particular, it's a new waiver that's applicable specifically to the homeless. We think that there is a lot of advantage for Georgia maximizing our ability to use these Medicaid funds in useful ways. Now, those of you may remember that last year, one of the bills that was passed was House Bill 610 that did direct Georgia to look at the waivers for treatment for substance abuse and for mental health. And our last presenter is from the Department of Community Health, and that's Brian Dowd. He is the expert on this. We found his presentations very informed, and he's going to give us a brief update on where Georgia is so far in proceeding with these waivers. Brian?
Thank you. Thank you very much. Expert scares me, but I'm still going to go with it. So I'm Brian Dowd. I'm the Deputy Executive Director over Policy Operations and Compliance at the Department of Community Health, which is just a fancy way of saying I'm the policy guy. Forgive the glasses. My niece gave me a box of reading glasses, and I never know what they look like when I pull them out. So today you get leopard skin, I guess. Medical assistance plans is a fancy way of saying Medicaid and Peach Care for kids. Mission of the Department of Community Health, we always start with that. So IMD waiver background, as Dr. Fitzgerald said, we were instructed to authorize private institutions to pay for institutes of mental disease and for substance use treatment disorder. It is correct that there is a federal exclusion in fee-for-service Medicaid for paying for institutes of mental disease. So you do have to apply for an 1115 waiver to pay for it in fee-for-service Medicaid for institutes of medical disease. Now, CMOs have flexibility, right? The CMOs have in lieu of services. So the CMOs are allowed to make payments for institutes of mental disease up to 14 days, but we are precluded from that in Medicaid without an 1115 waiver. 1115 waiver is just a demonstration waiver. People talk about it a lot. Medicaid has a state plan. It's like your book of service with insurance. It says, these are the things we're going to cover. Who are we going to cover? And what's our way of covering them? But if you want to do something outside of that standard book, which is our state plan, you have to apply for a waiver with the federal government. You may have heard of home and community-based waivers, which are extra services that we provide folks to keep them out of nursing facilities. 1115 is a similar waiver that says, hey, we're going to do something that you don't normally do in Medicaid as part of the state plan. And we're going to show you that it's cheaper and it's better for our members if we do so. So we were instructed to do so. So in July 2015, for substance use disorder, the Centers for Medicare and Medicaid Service issued guidance on new service delivery opportunities for folks with substance use disorders. And in 2017, they issued guidance revising the 2015. The big one was in 2018 when they said, hey, states, you can now cover payments to IMDs if you apply for an IMD waiver. Now, with like anything with the Centers for Medicare and Medicaid Services, when they are paying 2/3 of the payment, they have some things they would like for you to do before they approve it, right? So for substance use disorder demonstration, there are 6 categories of things that they want you to do, and you have to meet 17 milestones in order to enact 1115 waiver. They are everything for, and we have them outlined here, and I know it's impossible to see that slide, and I apologize about that, but hopefully you have a paper copy. Even then, it's a little small, but they are in the Medicaid Director's Letter. It's where they're pulled directly from. They're everything from access to criticals of levels of care to widespread use of evidence-based criteria placement, use of nationally recognized evidence-based substance use disorder program standards to set residential treatment provider qualifications. So we have to go in and set specific treatment and entry provider qualifications, sufficient provider capacity at each level of care. This isn't just the institutional level of care. This is the community level of care. So we have to ensure that the community level of care that an individual would transition from has sufficient provider capacity. We have to implement a comprehensive treatment and prevention strategies to address opioid abuse, and we have to improve care coordination and transitions between level of care. Now, for the substance use disorder provisions, most, if not all of these, allow for the first 12 to 24 months of the 1115 waiver approval to reach these milestones. So they often know that a state is not up to par with what is required from the federal government when you submit it, but they do give you 12 to 24 months to get to that standard. When it comes to serious mental illness or mental health, there are 5 categories that the federal government requires to approve your 1115 waiver and operate your 1115 waiver with 19 milestones. Those include ensure quality of care in your psychiatric hospitals and residential settings, which are things like accreditation. How are you going to do oversight and auditing? How are you going to ensure that you're doing an appropriate level of care for those individuals you are admitting? How are you going to screen enrollees for comorbidity factors in physical health? You have to improve your state's care coordination and transition to community-based services. And that has all kinds of case management, care coordination. You have to develop state strategies to prevent length of stays in emergency departments, for example. You have to increase access to continuum of care, including crisis stabilization services. Again, this requires statewide capacity. You have to have engagement and treatment through increased integration, so specialized setting, education programs, utilizing non-specialty care settings to increase engagement and treatment. And then you also have to have kind of a nebulous health IT plan. And CMS has said that they would provide more information as we continue through the demonstration on how IT interoperability has to be met. So Georgia went back and said, okay, I just went over all that in like 4 minutes for y'all. And you're like, that's way too much stuff. And I appreciate that because it is. But we went back and picked apart every single thing and said, where do we stand in fee for service versus where do we stand in CMO for these things, right? And we did a gap analysis on what that would take. We ranked stuff, and by the way, we did this in collaboration not only with our CMOs, but with the Department of Behavioral Health and Developmental Disabilities, because often those community services are in the 440 pack, what I think of as the 440 package, which is the community behavioral health option within, but we do have some services, but they're mainly for children that are in the Medicaid state plan. So we did all these different analysis of each of them, and we basically came up with some cost that we are going to have in order to implement. The first is just the cost of actual treatment. So I've seen some things that say, wait a minute, if you implement an 1115 waiver, it's cheaper for a state in the long run. I don't doubt that it is, and I don't doubt any of those metrics that have done that. And it's also cheaper for some departments within a state government as well. But for us at the Department of Community Health, we would be opening codes to cover the Institute of Mental Disease, which we don't currently have allocated for. So we would have to have that funding to allocate for that coverage. We also have to develop inpatient substance use disorder, rehab certified inpatient substance use services, detox medically managed services, and supervised medically managed services, as well as a residential per diem for transition. When you add all that stuff together, we estimate it's around 32 million in state funding. That's a high estimate. Our consultants used a similar state that was up and running a little more robust initially. We don't think it would be that high of a cost. It's also, but that's like a high estimate. It's also important to note that that doesn't cover things like IT related cost, coordination of care, or administrative cost within the Department of Community Health or the Department of Behavioral Health and Developmental Disabilities to run and manage the 1115 waiver. So these implementation considerations are all those things I kind of just talked about. We will have to demonstrate milestones to CMS. We have some infrastructure development. The gaps will be greater in fee for service than they are in CMO, because CMO is already covering in lieu services. And if you know our population, we got about 2.7 million people in Medicaid nowadays. Since the public health emergency, it's actually more than that. 600,000 of those are fee for service. 2.1 are covered by the CMOs, and our fee for service population is the age blind and disabled population. They are folks who are receiving SSI or RSDI, which is Retirement Survivors Disability Insurance, and are on Medicaid by virtue of being in a nursing home or historical SSI payment receipt. So most of this population will be in the ABD population. We will have to work some on integrating services between community and institution. And there is a consideration again of staffing both at ourselves and DBHTD to run that, which is something we're considering and working on now. That's really it for the presentation. We did include the actual gap analysis so you guys could see it as well, which is where we broke down every single point of it by fee for service and CMO. So we could be transparent on where our gap analysis is. Thank you very much for your time.
Thank you very much. So our recommendations
All
from
right,
our
if there's
committee
any
have to
questions
do-
of this presenter, and if not, we will take other questions. Give me just a minute. Ms. Skinner.
Yes, it's not a question for you, Brian.
Oh.
It was about one of the previous presentations, and the first question was.
Ms.
the one-
Skinner, excuse me for interrupting. Can you pull your mic closer so the folks online can hear?
Sure.
Thank you.
Is that better?
Yes, ma'am.
Okay, the 150 crisis beds that were suggested for Fulton County, were those suggested for adults, or is that a combination of adults and children?
Hi, thank you. To my knowledge, that is for both children and adults.
Dr. Fitzgerald.
Yeah, give us just a second. She's trying to answer.
Yes.
Okay, go ahead.
My understanding it was for children and adults.
All right, Dr. Fitzgerald, we've made an adjustment here. Can you repeat your answer to the question?
Yes, my understanding was it's for children and adults. But again, you're talking to the folks that we ask, how many would we need? And so that was, you're talking to the people that came up with that number.
Okay,
you.
and then the other part, and it's really a comment, it's not a question. When they talk about children who are not accepted by the provider community for admission, I think part of the time what happens is that the children are very complex and they require services such as one-to-one supervision. And a lot of times that is not approved for them. And so the providers are reluctant to admit without that support in place. I also think one of the reasons is because one of the things that happens with the emergency rooms where children remain in the emergency rooms is that the psychiatric residential treatment facilities in most cases cannot refer to themselves. And so you're looking for their community provider in most cases to make the referral so that they can go into treatment. And many of the kids don't have a community-based provider. So you're looking for someone who doesn't know the child to make the referral to say that they need intensive treatment. And I think it's something that we have to address. And then the last comment is the administrative burdens for the providers are real and it drives up our cost. And so I think that it's something that whenever we have the opportunity to address those or consider those that we need to.
I think you're absolutely right. And I was not in any way suggesting when I said we track it, I was not in any way suggesting that we should be punitive. But I think we need to be descriptive. I mean, if we have a need, for a significant need for a one-on-one, really and truly tight security kind of situation, we need to know how many of those beds we need, because right now we don't. Right now, we know from the testimony we had that it takes 3.5 times longer to transfer somebody with behavioral health needs than to just transfer, say, somebody with a heart attack. So we know but that's too generalized, in my opinion, for us to come up with a plan on how to solve it. So that was the reason for the following that information. So we'd see exactly what we need.
Oh, I agree.
All right, thank you. Any other questions of Dr. Fitzgerald's presenters? Dr. Fitzgerald, you want to wrap up?
Yes, thank you so much. So what we're saying is we need to come up with direct laws about network adequacy. We need to really look at the Medicaid waivers, and we have suggested that, and you've seen their progress so far. We need to look a little closer at the admission process. And one last testimony that we heard that we thought was particularly helpful. We heard from PHIC, which is the pediatric, that's been a statewide existence. They have looked at how to coordinate care. Their work was so impressive that we called and made a direct connection with the Department of Community Health. We really think that whole business on how to coordinate care needs to be in relation with these people that have been trying to coordinate care and have made some progress in it. So we introduced them to the Department of Community Health, and we suggested that they serve on their board that's looking at the kind of networks we should look at to take care of Georgia's children. So thank you very much.
Thank you, Dr. Fitzgerald. Any other comments before we move to the next section? All right, next up is Judge Amaro, and I think you're number 10, but this is our involuntary subcommittee. So Judge Amaro.
Thank you, Chairman Tanner. I'm a Superior Court judge, so this familiar faces problem that Justice Boggs speaks of plays out in front of me every day, all day. And so I want you just to imagine for a moment that I'm a 53-year-old man with schizoaffective disorder. I'm at home on a Sunday afternoon, and I'm with my mother watching television. Suddenly I start to decompensate. I start to feel anxious, start to get agitated, start to see snakes coming out of the walls. Next thing that happens is I get up and I try to defend myself and my mother against this imminent attack. I'm swinging in the air, punching holes in the walls. And my mother is concerned. She stands and she comes over, she tries to calm me. Well, what happens to her? I elbow her inadvertently, knock her to the ground. Next thing you know, she's understandably frightened. At that point, what happens? What happens next? She calls 911, thinking that the people on the other end of the line are there to help her and to help him and to connect him to treatment. Well, what we know about that contact is that that doesn't always go the way that folks expect, and it can lead to tragic results. How do we respond to these people in crisis? Generally speaking, not very well. Far too many, as Justice Boggs was speaking of, are arrested and languish in local jails for months until we figure out what to do with them. Far too many are transported to emergency rooms where they sit in hallways for days, sometimes weeks, until space frees in a more appropriate facility, as you've heard others comment. And as the committee was focusing and hearing this testimony from people over the course of the summer and the fall, focusing on this crisis response problem, seeing how these systems and resources have been overtaxed and overwhelmed, we reached an uncomfortable and inescapable conclusion, and that is that the entire continuum of care needs a thorough audit. From low acuity to high, from non-emergent to emergent, we need to know what treatment is working to prevent crisis and what is not. When I asked the department, what happens to this person to whom you deliver, for example, intensive case management services, 3 months later, 6 months later, do they re-enter the continuum of care at some other point? They don't know. When I asked, do you know whether this person who you've delivered these services to has been arrested or not within 6 months, 12 months? The answer is the same. We don't know. Well, that's not part of a key indicators analysis, they say. And those of us on the committee who've discussed this and heard this, we believe that it should be. Before we can even begin to make recommendations regarding resource development and allocation, we need to better understand what's working to stem the flow of people with SPMI into state hospitals and criminal justice and what's not. We hope that the next commissioner of DBHDD will perform this audit immediately. We believe this audit will result in insights that drive the work of this committee in the coming years and help us to make recommendations that will help reduce arrest, reduce hospitalization, and reduce incarceration of people with SPMI in crisis. Turning now to some of the recommendations that the subcommittee is making. The first is a set of recommendations that come from Brian Stetton, who is formerly legal counsel to the Treatment Advocacy Center and now senior advisor to the mayor of the city of New York on matters involving severe mental illness. And he'll be talking about ways in which we are hoping to refine the AOT provisions that were adopted last year in House Bill 1013. Brian, are you with us?
I am. Thank you, Judge. Great to be with you and the committee. I should start by just making clear that, as Judge Amero said, I am now working at City Hall in New York City, but I am not here in any way to represent the city of New York. In my former capacity as policy director of the Treatment Advocacy Center, I worked closely with Judge Amero's committee in developing those AOT recommendations. And so I'm happy to just kind of share my thoughts on the final version of the legislation that was enacted, but that's obviously not something that the mayor of New York City has any interest in weighing in on. So let me just give a kind of brief overview of what AOT is for those who aren't entirely familiar. Right, AOT is outpatient civil commitment, is the practice of placing an individual who has a history of cycling in and out of treatment and the criminal justice system, of being kind of caught in that revolving door as a consequence of their difficulty engaging with treatment on a voluntary basis, under a court order. Which is a mutual court order, right? It's also a court order that places the mental health system under the supervision of the court, such that we can say to the person, we have an expectation that you will adhere to a program of treatment, and we also have an expectation that the system will deliver this set of services that have been determined to be necessary for you to survive safely in the community. And the idea is to leverage this black robe effect, right? It's not about scaring somebody into submission. There are no real consequences of in terms of punishment of being in violation of the order. Any real teeth associated with this are simply in that it's a violation of the court order may facilitate a little bit of an earlier opportunity to bring somebody in for an evaluation to see what their condition is, but certainly it's not about anyone being held in contempt of court or punished in any way. The idea is simply that having a judge engaged in a person's life, very much in the way we see in mental health courts that have been successful around the country for people who are involved in the criminal justice system. Through this form of civil commitment, we can take a person who has a history of disengaging from treatment, give them the benefit of having a judge involved with them, giving them some kind of motivation and inspiration, checking in with them periodically during the period of the order to see how they're doing, and help them to develop habits of treatment engagement. And this is a model that has been proven a best practice throughout the country. There's great data behind it. It's something that has existed on the books in Georgia for many years, but fair to say has been vastly underutilized. And so the idea of this grant program that was established under the Mental Health Parity Act enacted last year was to stimulate the development of some real AOT programs within Georgia that will establish the efficacy of this concept. And there's an evaluation piece connected to this as well, where we can establish not only that this leads to better care for folks, but that it also saves the system a great deal of money, because making those investments in upfront care are so much more cost effective than picking up the pieces of crisis again and again, where we're hospitalizing people and arresting and prosecuting people, so that it should become a no-brainer on a purely fiscal level as well as a therapeutic level, that this is something that ultimately should be just a standard practice in every county in Georgia. So with that said, I was involved in drafting the language of this grant program that would have the Department of Behavioral Health and Developmental Disabilities put out an RFP and have numerous counties apply and several receive these grants to receive these initial opportunities to establish AOT programs, and kind of take away the excuse that, well, we don't have the funds to get this off the ground. And, having drafted that initial language that was incorporated into this committee's report to the legislature on what this grant program would look like in terms of legislation, I was a little surprised to see that the initial version that was later put forward as legislation, what was initially part of the House bill on this, there had been inserted into the language a requirement that applicants for these grants affirm in their applications that they will only offer AOT to individuals who meet certain legal criteria that were added. And in looking at those criteria, I recognize them immediately as the law of California, right? The AOT eligibility criteria that are on the books in the state of California, at least as they existed a year ago. Actually, by the time this legislation was advanced in Georgia, those criteria had already been amended because of one of the problems I'm going to get into momentarily with them. So California had already kind of moved beyond that legislation. But, I found this odd and unfortunate for two reasons. First, this grant program that was created, that was proposed for Georgia, was not establishing AOT as some kind of a new legal option. As we've said, this has been on the books for a long time in Georgia, and Georgia law already establishes a set of criteria for AOT, and they are really as good as any state's. So if you look at the definition section of the behavioral health law in Georgia, section 3731, paragraph 12.1, it defines what it means to be eligible for AOT in Georgia. And it basically must be proven by clear and convincing evidence that this person is in need of involuntary treatment, that is, they're unlikely to be able to do this voluntarily. They are unable to voluntarily seek or comply with outpatient treatment, and that they are in desperate need of outpatient treatment, that without it, they are likely to become dangerous to themselves or others, even though they may not be at the time we are placing them in this program. That is, it's meant to be used for folks who are coming off an inpatient stay and may actually be doing well at the moment we want to place them under this order. So it's much more about their history than about their current condition. So, those are the criteria that already existed. And from my point of view, there was no need to write additional eligibility criteria into this grant program. We could simply kind of pick up from, where the law already left us in Georgia. So that was the first level on which I was kind of troubled to see that there was this new set of criteria that had to be followed by any of the counties that were going to take part in this program, because effectively we were saying that we would now need to screen people through two sets of criteria, the existing Georgia law, and then in addition, the California law. And, it was kind of beyond me why we would want to exclude from these grant funded programs anyone who already met the Georgia criteria. But even beyond that, the fact that California's were the ones chosen was vexing to me, because as someone who has become kind of a national expert on this issue through my previous work at the Treatment Advocacy Center, having gotten very familiar with the AOT laws of all the states, California's is actually the last state I would have chosen as a model for how to draft AOT eligibility criteria, because I know from the work that I've done that there are significant flaws in those criteria which have really stymied the effective implementation of AOT in California. Not to say that there aren't some decent programs, but to the extent there are, it's because they have found workarounds to get past some of the problems that those criteria present. And there are many programs that just are effectively AOT light, that just aren't really full AOT programs for reasons I'll get into. And so that kind of gets me into what exactly I think are wrong with these criteria that have been adapted as a second set that must be followed to obtain a grant under the Georgia law. So just very quickly, I'll kind of mention three kind of big issues. One thing is that the California criteria require a finding that the person at the time they're receiving AOT be substantially deteriorating. And this is the one that California has actually already moved past because of for the reason I'm about to explain. They recognize that this was stymieing their implementation of AOT and they've wiped it out. But the idea here is, that we can actually use AOT for someone who is doing well at this moment, because the judge has to find by clear and convincing evidence that at the moment that this decision is being made, this person is substantially deteriorating. So the idea of using this at the optimal moment when a person is coming off an inpatient stay and is actually doing pretty well, they've been stabilized through their hospital care, is off the table when you have to find that they are substantially deteriorating now. Secondly, the California criteria require that before you can move to AOT, you have to establish that the person has been offered an opportunity to participate in the treatment plan on a voluntary basis, and they have refused that and continue to fail to engage in treatment. And as reasonable as this may seem on the surface, in practice in California, it has led to a very unfortunate approach to AOT, because they tend not to look at previous attempts to engage the person in voluntary treatment. This has been interpreted to mean that we can't offer AOT to somebody unless they, at the time that they have been deemed eligible for it, have been offered this kind of off-ramp of voluntary services. And if they say yes to that, as most people will, because they kind of see the writing on the wall that they meet the criteria and are likely to be court ordered if they don't, that has resulted in an implementation of AOT where most of the people who are ostensibly in this program are actually not under court order and not receiving that benefit of having engagement with a caring, inspiring judge, right? That black robe effect is kind of removed from the picture when most of the people participating in AOT, in quotes, are doing it on a purely voluntary basis without a court order in place, and the court doesn't have any basis to be engaged in that treatment. So that's really unfortunate. The third kind of major problem with these California criteria is that there's a look back. There's a very specific requirement that you have to look and find that the person has been hospitalized twice in the last 36 months. And there's this very strange exclusion from that, right? It says that you have to exclude from that look back period any period of hospitalization or incarceration, quote, immediately preceding the filing of the petition. So what that effectively means is that if the person is currently hospitalized and we're using AOT as discharge planning, which is, again, typically the way this works, we can't use the current hospitalization, right? The disengagement from treatment that led to that current hospitalization as one of the two we're looking at in the last 36 months. That's excluded from consideration. So we effectively have to find 3 hospitalizations in the last 36 months. It makes no sense. There's no reason why you would exclude that most recent incident just because it led to a hospitalization that is currently ongoing at the time the person's in court. There's kind of an arcane, obscure explanation for how that wound up in the law that I think is just bottom line. It was unintentional, but it's just not a mistake that Georgia should repeat. And so this all kind of leads me to the recommendation I would make that we simply just take this out of the requirements that must be met for a county to participate in this program in Georgia. There's no reason to add a second set of criteria. Just make this eligible to all people who meet the current Georgia criteria. I realize it's a little problematic because these grant applications, I think, have been awarded at this point. I know the RFP has gone out. And so there are counties who are participating now who have already had to assert that they are going to follow this second set of criteria and the people that they bring into the program. But I think, to take this out of the law would at least allow those counties in the second and third year of their grants to open it up to a wider set of folks and really maximize the potential of this program to be as effective as possible and meet its true and great potential. So that's the information I'm happy to share with you today. And again, I'm happy to take any questions.
Well, thank you so much, Brian. And not only for your testimony here today, but your work on behalf of the subcommittee this year and in years past. We really appreciate you and your expertise. Is there anybody who has any questions about this change that Brian's proposing and that the subcommittee's endorsed? Any questions online?
I'm sorry, I haven't read your complete report that came in. Have you given us page and line numbers and statutory specific language for your suggestion?
I have. Yes, that's in the report.
All right, thank you. And regarding the implementation of the grant program, we are in year 1. And as Stephanie Lopez Howard's making her way to do our next presentation, I'm just going to reach out to Judge Sarah Harris, who's been involved in the AOT implementation committee, and ask her just to give us just a 30-second update.
Thank you very much. Thank you very much for having me here. And I enjoy being part of this committee. And I can say that the familiar faces, the days in the hospital, I can affirm that in Middle Georgia, I think we hold the record of 482 days. Someone in a hospital that was ready for discharge. So that being said, the report about our AOT progress, we have 2 types of grant situations. We have first DBHTD started before HB 1013 was even passed. They started a grant program through SAMHSA. Muskogee County was our first court, and really the only court at the moment that is up and running. They had their first participant in February of this year. They currently have 15 participants, all with serious persistent mental illness. What have we noticed and what are the positive results? A noticeable improvement in housing stability that across the board is one of the factors that everyone has recognized because of the intensive hands-on case management. Repeat hospitalizations and crisis intervention points have significantly declined. In fact, there are 2 that actually came out of the jail. One of them had been a monthly visitor to the jail, and he has not been incarcerated since April. and he has been in this program. The other one was a little more difficult case, but is managing to maintain since June. So we consider that some progress. The challenges have been, of course, staffing. It took several months into the program for us to find someone to lead the program. And we still need a peer support specialist. In fact, we haven't even since December gotten an application in Columbus for a peer support specialist. Additional costs have been approximately $5,000 for court-appointed attorney's fees. That'll continue to rise by the number of people in the system and working through the program, and the flexibility they need for the criteria in AOT. The SAMHSA grant is a little different than the AOT grant funding through 1013 because we've taken the position that we're not exactly tied to that funding, the criteria in 1013. So some of the people in this program loosely fit the criteria in 1013, but some of them definitely do not. And they're working through the program as if they were just through our normal outpatient treatment. The AOT grant program let me back up. Gilmer County is also going to be awarded. They have been awarded the other SAMHSA grant, and the contracts are out to be signed, and hopefully that's going to be up and running by the end of the year. They'll cover 2 counties, actually. It's Highland Rivers, and they will actually cover 2 counties, Gilmer, and I'm not sure what the other county is going to be. So then on to the AOT grant through 1013, there were 10 applicants. Awards are expected to go out in the next 5 to 7 days. DBHCD is actually ahead of schedule on awarding the grants. There were some delays in trying to determine whether this was a contract or this was a grant program, and they had to get some AG office advice on that. But they've moved along, and I can tell you from the number of meetings I've had, I feel like I should be being paid as a member of the staff of DBHCD because we have met literally for 6 months every week. We've just dropped our meeting schedule down. So it's really been a lot of work on the part of a lot of different people. The 10 communities, I will tell you, that are interested in this pilot and that applied for the grant. I think this is important to say. There were several more communities interested, but because of our timeline and a lot of lack of knowledge about the AOT program and how it was going to work and how it was going to run, some of these communities didn't really have the time to put something together, especially because they had to work with community partners. And as we all know, getting those groups together can sometimes be difficult. And the applications themselves were really dependent upon the provider. They were the ones who had to apply, and they had to be the driving force. Although I can say there were some probate courts that were very much the driving force behind it. But that's really the report that I can give you, the update. We still, of course, need a lot more data, and I can tell you that our data fields are extensive. So we hope to have a lot more within the next year.
Well, Sarah's been fantastic. And David Sweat, who's a Superior Court judge, who's recently retired, is also a member of the implementation committee. And we greatly appreciate both Sarah's work, Judge Harris's work, and also the work that we are seeing from the other committee implementation members. Let's go ahead now and shift to this data sharing, to this data work. And one of the recommendations, the second recommendation that we have as a subcommittee is that we fund Criminal Justice Coordinating Council research into data sharing between criminal justice and behavioral health. And Stephanie Lopez Howard is the person who we have reached out to routinely over the course of the last several years whenever we have a data question with the Criminal Justice Coordinating Council. And Stephanie, why don't you tell us a little bit about what you're doing right now to address the data sharing issue and data mining issue, and what you see as the next steps.
Thank you, Judge Amaro. Thank you, Mr. Chairman and members of the commission for the opportunity to present to you all on recommendation number 2 of the involuntary commitment subcommittee. Let me just preface by giving you a little bit of an introduction to me. My name is Stephanie Lopez Howard. I've been working with the Criminal Justice Coordinating Council for 12 years, and for the last 10 of those 12, I've been the Statistical Analysis Center Director at CJCC. The function of the Statistical Analysis Center is to be responsive to one of the charges in our enabling statute around criminal justice research and data coordination within the criminal justice system. One of the things that has been a persistent problem and that we have heard over time from many criminal justice system stakeholders is the interaction that people with a psychiatric illness have with the criminal justice system. And so in 2018, I kind of embarked on a little bit of a journey to actually try to capture what that means, in part actually based on a request from DCH to try to understand the percentage of folks in county jails who have psychiatric illness, to craft a waiver around that, potentially craft a waiver around that for Medicaid eligibility. And so I did. We received data from 9 county jails, and we matched those data to computerized criminal history, Georgia Department of Corrections, Department of Community Supervision, and did an analysis to attempt to estimate the prevalence of people with mental illness in those jails. It's a conservative estimate based on a flag for mental health screeners in the Department of Community Supervision, as well as anybody who has had a felony conviction and a prison stay, and has been on an elevated mental health level during that prison stay. Our findings are very briefly, right, that about 15% on average of all jail bookings during the 5-year study period involved someone with psychiatric illness, potentially based on this screener, right? And that amounted to about 9% of the people booked. We did a familiar faces analysis that looked at the 99th percentile of people booked during that time period. That means you have been booked so many times that you have been booked more than 99% of the people in the sample over the 5-year period. That was about 2,000 people. I'm giving rough numbers, but if you go on CJCC's website, both the full report and the familiar faces analysis is available. And of those 2,000 people, about 25%, this number I know off the top of my head, 649 had psychiatric illness, or at least potential psychiatric illness based on this mental health flag. Right? Those folks consumed, they were less than 1% of the total number of people booked, and they consumed about 2% of the jail beds over the time period. So it's a population, as you all have heard, right? Here we are beating a dead horse, that has a significant effect on the criminal justice system and is costly and revolves. So based on the presentation that I did to Judge Amero's subcommittee, he asked me to try to work with the Department of Behavioral Health to identify, or better identify, I should say, that prevalence estimate. For the last several months, I've been meeting with the Department of Behavioral Health and working through a methodology to take my big 9 jail data set that has information about people booked between 2013 to 2018 to match it to data from their claims management system and identify folks who have been in the criminal justice system and have also received services from DBHDD funded providers. So I'm going to take a step back and just say, I traffic, right, in administrative data sets. A lot of the work that the Statistical Analysis Center does is based on data that are collected by actors in systems throughout the state. Law enforcement, Department of Corrections, Department of Community Supervision. And in this instance, right, it would be data from the Department of Behavioral Health and Developmental Disabilities on claims that they receive. It would be akin to Medicaid claims data, right? Payments that they make. That allows us to look at things like the type of provider the person saw, the date for services. We're doing a look back period of a year before the start of the booking data, so 2012, and a year after the end of the booking data that I've got, 2019. To try to understand the overlap that people coming into county jails have with the safety net service system that the state funds. a couple of the things that we are hoping, right, hoping at this point, the research design is slightly inchoate, but we are working out a lot of the data transfer details and stuff like that. And how do you match across data sets and all that other good stuff. One of the things that we're hoping to look at or start to look at is temporality. When does somebody engage with public or Department of Behavioral Health and Developmental Disabilities funded services, as opposed to when do they engage in the jail? Is it a chicken, an egg? The chicken and the egg happen together? Like what is going on from a temporality perspective? What level of services are people who are engaging in both the criminal justice system and services funded by DBHDD? What level of services are they within the Department of Behavioral Health and Developmental Disabilities? Some of the services that we are particularly interested in looking at are the so-called DOJ consent decree services, and we're working with the DBHDD to make sure that we adequately define those based on their policy. We're also going to be adequately defining based on their policy what is called a high utilizer. It's a policy that came into effect actually later in what we would call our study period, but we're going to try to apply it retroactively in terms of measuring people who are high utilizers of the DBHDD system, who may also be high utilizers or familiar faces within the county jail data system. The reason this is important is this, among other things, right? The flag that we use to identify people who potentially have psychiatric illness is highly limited. I said it's a conservative estimate because it relies entirely on criminal justice data sets. And it relies on criminal justice data sets that presuppose that the person has a felony conviction. A person without a felony conviction, I know nothing about you. I know nothing about people who have no misdemeanor histories. And I hesitate to quote statistics off the top of my head because I cannot remember from the report, but a substantial portion, in fact, a plurality of the people booked during the time period had no felony conviction history that we were aware of. And thus we could not find them in the Department of Corrections or the Department of Community Supervision data set. So understanding the nexus between that population and the Department of Behavioral Health and Developmental Disabilities services will give us a much better and much more accurate estimate of the people interfacing with county jails and county jails and the Department of Behavioral Health and Developmental Disabilities. That work, as of now, I am proposing to fund, if I can get a scope change from the federal government, with a Bureau of Justice Statistics grant that I already have. The work that Judge Merrill wants me to talk about is what's called the touchpoint analysis that is proposed as part of recommendation number 2. And again, I want to preface and caveat by saying that this is a very inchoate kind of idea and somewhat nebulous. But as I was talking to Judge Amaro about it, one of the things that I was thinking is on the criminal justice side, I would consider, and having done very superficial kind of overview of what is exactly a touch point analysis, the gain sequential intercept model, somewhat of a touch point, right? You have intercept 0 through reentry, and what are the ways that people intersect with those different intercepts, what services are available, where are their gaps, where are their opportunities? The idea would be to do a similar exercise with the behavioral health system, understanding the different touch points, opportunities for entry, opportunities for exit. Where do people fall through the cracks? How much engagement do they have? And the interface, right? If you think about, you can think about it 2 ways. And actually in my conversation with Judge Amaro today, I was trying to think about how do you think about this? There's the first way, which is all of the Department of Behavioral Health and Developmental Disability Services technically are part of Intercept 0, maybe with the exception of competency restoration, right? So all of those services would be the start of the continuum. So you've got Department of Developmental Disabilities, Department of Behavioral Health and Developmental Disability Services, and all of these various different touch points until you get to potentially Intercept 0, and then we get into the criminal justice system. So that's one way to think about it, right? You're going from one end of the funnel all the way through reentry. The other way to think about it is as parallel touch points, where you can bounce between one touch point and another. That's all hypothetical, right? And one of the ideas behind a touch point analysis would be to define how do you think about it, because that's important for how you measure. So one of the things that would be propose, I guess, as part of a touch point analysis is understanding all of those places where people interact, and not just that, because again, administrative data, what data are collected about those persons at those intercepts, and how do you measure engagement, right? So that's kind of in very broad strokes, what potentially a touch point analysis that looks at both systems in parallel or as a continuum could potentially look like. And the kind of stuff that's involved in that, number one, having done at least a little bit of this and business process analysis and modeling, a ton of interviews, understanding different system actors, how the system operates at different levels, both at the state and at the local level. What does that look like? How are people accessing services? Where do the data live? So then talking to the data folks associated with those systems, is there a centralized place where we can find information? And what are the limits and scope of the information that's contained in those systems? And then actually starting to map. So create the map, understand the strokes around the interaction between the two systems, define the data sets you're going to want to use to measure, define the way that the data sets are going to be paired together, and then do the actual analysis at the different time points. Sounds really simple. I promise you it's not. I've done it. I've done much smaller scale things, and it is never easy. But those are the kind of broad strokes of what a touch point analysis would be. The phase after that, potentially, right? Or one of the things that could result from that is then opportunities for ongoing data sharing between the two systems. When do people need to actively exchange information between the criminal justice and the mental health system to serve the people who interact between the two, right? And how are those data going to be exchanged? Who needs to be part of those exchanges? How are those things crafted? There are already exchanges happening. There's the Gracie in the Savannah area, right? There are already health information exchanges happening throughout the state. The question is, how does that interface with criminal justice, right? And what kind of data do we need to have going back and forth? And I'll stop there.
Thank you, Stephanie. I'm concerned about time, and I apologize that we're going a little long. Any questions for Stephanie about this unusual approach? And I think it has great potential.
You chose 9 county sheriffs to work with.
Yes.
Is that because only 9 county sheriffs would give you data, or did you ask for volunteers?
So thank you for that question. We stratified the counties into different groups, rural, urban, suburban. The goal was to choose 3 from each group that would be representative, and we did outreach for those. So there was a little bit of a selection process on the front end, not just volunteer. There were some folks who decided not to participate. There was one county sheriff who said, please count me in. I want to know. And in fact, we are still working with 4 of the counties on a smaller scale.
I've done FOIA requests of many different jail for this kind of data, and they ignore the request totally.
All right.
Thank you.
Thank you, Stephanie. If there's nothing further, then I know you had an all-nighter, and it's you are excused.
Thank you, everybody.
We do have a question, Ms. Levi.
Oh,
yes.
I'm so sorry.
Hi, Stephanie.
How are you?
It's good to see you, and it's been very good working with you. Just wanted to make a comment regarding the work being done between Avita and Forsyth County, and would like to offer from the behavioral health standpoint, we're more than happy to move to the next step and take a look at the jail data and look at the intercept with individuals that have received DBHDD services through Avita's program. So maybe that could be the next step, and we'll need to connect.
Oh, that would be an awesome pilot. Thank you. Sure. Appreciate that.
And just for the record, nothing you said sounded simple. And Judge O'Meara never asked a simple question, so we all know. Thank you.
Both good points, Mr. Chairman. Thank you.
You can tell Jay Neal, though, that other agencies may be looking to hire you soon, so thank you.
I appreciate that. Thank you.
Go ahead.
Chair, if we could please now turn it over to Nora Haynes, who will talk to us a little bit about Open Doors to Recovery. We're recommending a funding of this on a statewide basis.
Hey, can you hear me? Am I on?
You're on, Nora.
Okay, I'm going to talk to you today about the Opening Doors to Recovery research project, which is now evidence-based. What I want to do is to give you a little bit of history, talk about the demonstration project, the ODR design, and then talk about the 5-year randomized controlled trial. And then I'm going to give you some results. And then I have a lot of people I'd like to thank. In 2004, DHR, which is now sort of DBHDD, NAMI Georgia and GBI began a partnership to do crisis intervention team training with law enforcement. So at the time, Gwen Skinner was the mental health director, and she agreed to fund CIT with the understanding that we did research. We did research, and CIT was a glorious program. Yeah. There was one problem. And the problem is that the CIT officers did not want to arrest somebody and incarcerate them, but they had no real option of where to divert them. So NAMI Georgia at that time went into all the behavioral health regions and had stakeholder meetings. So the Savannah area, which at the time was Region 5, took a particular interest in this issue. And they did what was called an all-out war on keeping the serious and persistently mentally ill out of institutional recidivism. At the time, the Bristol-Myers Squibb Foundation was involved and decided they wanted to take this Region 5 stakeholder group idea and fund it into a demonstration project. So we got $5 million from the Bristol-Myers Squibb Foundation and some other funders, and we started this demonstration project. It was a 3-year project to see if Region 5's idea about the Opening Doors to Recovery project was viable, if it would really work. So what we found was that we reduced recidivism by 52%, which was an indicator that this really works, but we weren't sure. So let me tell you a little bit about the design. Each of the participants in the demonstration project, and there were 100 of them, had 3 community navigation specialists. We call them CNSs. We had a professional, a family, and what we called a peer that we call a recovery CNS. And they focused on 2 chief goals: reducing recidivism in incarceration, hospitalization, and homelessness, and promoting recovery. And the way that recovery was promoted was 3 pillars. One was ensuring adequate treatment. We had safe and appropriate housing, the key word appropriate. We developed meaningful days for the participants, and we used technology to promote recovery. 2 other components were we constantly had stakeholder meetings, and we also had a partnership with the GBI where all of the participants were on the Georgia Crime Information Center. So when they interfaced with law enforcement, their case manager was called instead of taking them to jail or wherever. So that was the demonstration project. So because it had such a good an outcome, the National Institute of Mental Health decided to do a randomized controlled trial, which you researchers out there know this is the gold standard. So we started a 5-year randomized controlled trial, and there were 2 sites in Savannah and 1 in Brunswick. Thank you, Gateway. And we looked at 240 patients. We randomized part of them to ODR and part of them to intensive case management. So at the end of the 5 years, we looked at the aims, the things that we were looking at to compare. And ODR was the patients in ODR had less hospitalization, less arrest, better housing outcomes. And one of the most important things is they were in recovery. They were becoming contributing members of their communities. So the results were outstanding. So now the Opening Doors to Recovery project is evidence-based. One of the things I want to share with you, there's a lot of results that we shared in our committee meeting, which occurred in August, which you can access. But we looked at arrest. The ODR patients, there were 24 arrests, and intensive case management, there were 49 arrests. And we contribute that to the GCIC system, to the cooperation with law enforcement. So we're very, very happy and proud that this is an evidence-based practice. And Michael Compton, who is with Columbia University, he is our researcher, continues to research the GCIC component. He also has done a huge cost analysis on ODR, and he also looked at those patients who were arrested. What were they arrested for? And I found it quite interesting that the top 3 things that they were arrested for was probation violation, disorderly conduct, and willful obstruction of an officer. Imagine that for a mentally ill patient. So I want to thank NAMI Savannah for doing this project, NAMI Georgia, Dr. Risby, Dr. Charles Lee with DBHDD, June DiPolito, Mark Johnson, David Cruz. It just took all these people to make this happen and more. At this time, Viewpoint in Rockdale County is doing ODR with the jail population. So I want to do a shout out to Commissioner Doreen Williams and her Stepping Up staff, Brenda Ernest and Bill Carruthers, and our wonderful ODR team that I hope are watching. They are working really hard. So Judge Amero, ODR works.
Yes, ODR works. And one of the things that I've spoke to the Council of Accountability Court judges about is perhaps having their participants also enroll in the GCIC component. And the current president has agreed that this would be appropriate. And there's 7,500 people in those accountability courts that could potentially benefit from this at a time when they decompensate. All right, so that's funding Open Doors to Recovery. The next is, this is our last presenter, is Karen Bailey, Dr. Karen Bailey, who's got 30 years of experience in forensics. She is going to talk very briefly about the diversion of folks from the competency restoration process.
Can you hear me? Judge Amaro, can you hear me?
Yes, ma'am. Go ahead.
Okay. So the issue of incompetent defendants is a significant issue for Georgia, and it is reflective of a much larger national-wide issue. And simply put, the issue is that defendants who have psychiatric or cognitive disabilities which prevent them from participating in their legal proceedings are lingering in jails waiting for court-ordered competency restoration services, which is just basically a service or treatment to improve their ability to factually or rationally understand the legal system and to enable them to work with their attorney. The problem is caused because there is a finite number of beds in the state psychiatric system, and that system must also provide services to individuals who are not in the criminal justice system in our state. This places a drain on the county jails as people linger for a state bed. It also places a significant burden on the defendants themselves as they lose their jobs, their housing, and sometimes their social supports while they're waiting to get a place for competency restoration. The interesting part, or the sad part of this, is a significant portion of the individuals do not need, and some do not even benefit from being placed in a state hospital in order to get this service. The service can be done on an outpatient basis in many cases. So this is where outpatient commitment can be very helpful. It can be used to divert individuals with low-level offenses at the earliest point after their arrest, instead of investing significant resources in competency restoration, if the desired outcome is for treatment and not necessarily prosecution or punishment. And this is true in a majority of the state court cases. When you talk to state court judges, that's what they will tell you. It is also true in cases where their prosecution is the goal, there's still a sizable group of individuals who could receive their restoration in the community. If the judge determines that they are qualified for a PR or a low-level bond, that restoration could be done in the community rather than in the hospital. And then there's also those people who might need the hospital for a short period of time, but then could continue their restoration in the community rather than the hospital. We all seem to think that this is a novel idea, but if we all think about physical health, years ago, many operations were done inpatient. We had to go into the hospital that are now done outpatient. It is the same thing we can do in mental health that physical health has been doing for years, is people do short stays in the hospital and much more recovery in the community. This model could also be done with outpatient restoration through an outpatient commitment model. And then the final recommendation I've given our committee is that those people who do with more severe crimes, who do stay in the hospital system for a long period of time, are eventually released, and the superior courts monitor these folks. The monitoring of these folks could be due through an outpatient commitment with probate court, especially after significant time after a few years. This would also free up resources for superior court judges. So trying to go quickly, the takeaway is that outpatient commitment could be used in competency restoration. It would match the intensity and severity of the situation with the level of resources that we're using. It would free up the higher end resources for individuals who really need that level of service, therefore decreasing any waiting lists. And the earlier the diversion, the less stigma and more likely individuals would be successful on their return to the community.
All right. Thank you, Karen. Just as a side note, in Georgia, more than 1,000 people are waiting evaluations to determine their competency to stand trial on criminal charges. More than 350 people are waiting mental health competency restoration services so that they may stand trial. It can take them up to 20 months for this to occur before they even begin their criminal case. All right. And most of them are spending their time in local jails waiting for restoration services for 10 months. All right. I have some other recommendations, but they're all in written form and they're part of the record. What I think that we need to do, at the interest of time, is just very briefly say that we totally concur with the hospital and short-term care facilities recommendations about the number of beds that they need. 150 sounds about right, although I think that we need to do a deep dive into determine exactly how they determine that number. Piedmont Healthcare Systems presented to our committee and said that emergency departments are the central intake point for patients who need transport to emergency receiving facilities pursuant to 1013 certificates. Due to lack of available beds for evaluation and treatment, patients are commonly held days or weeks in emergency rooms awaiting an appropriate placement. This result delays necessary care for those patients and impairs hospitals' ability to care for other patients in need. In 2021, Piedmont had 18,751 encounters with behavioral health patients, resulting in $18.7 million in uncompensated care and over $3 million spent on contracts with private providers to care for these patients. This is unsustainable. All right. I'm going to just rest on the record for the remainder and turn over the mic, Chairman, to our next presenter.
Thank you, Judge Amaro. Thank you for that presentation. All right, next up is our Workforce and System Development Subcommittee Chair, Representative Mary Margaret Oliver.
Thank you, Mr. Chair.
Let's see.
I don't believe we've had a recognition today of a very important announcement that the governor's made, 10:30 this morning, that our chair, Kevin Tanner, has been named the Commissioner of Behavioral Health. Developmentally disabled. I think that deserves some recognition by all the folks. I look forward to working with you. I hope you don't decide against taking the job after hearing all these problems. The Workforce and Systems Development Subcommittee has a lot of interaction and overlap with every other committee. Work staffing and workforce is an issue for everybody. And I appreciate the opportunity I've had to talk with members of other subcommittees and other chairs and folks that are overlapping in this area, and some of the discussion then recommendations may relate to some of those discussions. I also particularly want to thank Ashley Dixon and Ms. Nesbitt, Chelsea Nesbitt, who's helped me a lot, and Renee Johnson from Georgia State. I've been out of the city for a while on vacation, just being a real pest to Renee Johnson about this report going back and forth. So I thank her for her help. We, in recognition of the staffing issues and the data collection issues, have collected in general some information that's very helpful to us to begin to define the problem. The CSBs gave me a document Behavioral Health gave me a document that showed the extent to which salary increases that we've already given to a variety of employees in categories, treatment service categories, the extent to which we have raised salaries in the recent history based on the crisis that we're seeing. And that document is in your packet. They have not given me the vacancy rates in behavioral health, but the community service boards have given me vacancy rates of treatment facilities, and it's very distressing if you have a 31% vacancy rate for counselors and therapists in those statewide CSBs. The issues of workforce development are simply very, very huge and will continue to be for the immediate future. I think before we go further into the recommendations, I think Elizabeth Holcomb is with us today and wants to give us a discussion about the data analysis and data collection issues that are set forth in the recommendations of the report. In relation to the data collection issues, I think y'all may remember that Senate Bill 374 was passed by the Senate in the 2022 session, and it provided a legal framework for the Georgia Office of Data Analysis to be a subset of every other agency. That is a legal framework that would facilitate data sharing. And it's a very good first step to break down the barriers and break down the silos in the way in which agencies are struggling to share data. Elizabeth Holcomb, who is with the Health Strategy Commission with Grant Thomas, has written a paper that does a survey of all the states that have addition to legislation, either by executive order or by legislation or by interagency MOUs, have implemented different strategies for data sharing. And I think Ms. Holcomb would probably be most helpful at this time in going through your paper if you would focus on the specific examples of what other states have done, and then we'll talk about some of those examples in our recommendations. Thank you for being with us today.
Thank you. Good afternoon, Chairman Tanner, Commission members. My name is Elizabeth Holcomb. I currently serve as the Deputy Director and Legal Counsel for the Governor's Office of Health Strategy and Coordination. I'm very excited for this opportunity to join you today and present to the full Commission a little bit of a summary of what I've previously provided to Sub-Chair Oliver's Subcommittee on Workforce and System Development. I'm going to, in the interest of time, I'm going to speed through a couple of the slides that just going to give a background of the office just very quickly. We've Governor Kemp appointed Director Grant Thomas in June of 2021. We consist of a staff of four full-time staff with a mission to break down the silos between government agencies, healthcare providers, and healthcare consumers to promote healthcare policies that increase access and quality. So over the last year, we have examined various issues related to the practice of data sharing in state government and approaches taken by other states. While some agencies do not have a need to share or receive data from another agency, there's an undeniable benefit for state agencies with shared clients or patients spanning multiple programs and delivery systems to be able to share data.
This is especially the case for states' health agencies. They're organized in silos, which is why we kind of stumbled upon this issue, given the focus of our office. From my research, several states have recognized the important role that data can play in enhancing delivery of services and improving overall inefficiencies by establishing frameworks for statewide or interagency data sharing. When I use the term interagency data sharing, I'm referring to any exchange of data between two or more agencies. And the practice of statewide data sharing refers to a state's overarching system and policies for data sharing between its agencies. I'm going to fast forward a little bit. In short, states' approaches to data sharing varies, but they all seem to approach it from either a combination of the four things: executive order, legislation, task force committees and commissions, and the use of formal data sharing agreements, often called memorandums of understanding or data use agreements, or both. So, of course, you can't invite an attorney to present without touching on the legal framework and considerations. You know, the practice of data sharing, whether it's in the public or the private sector, is governed by federal and state laws that depend on the entities seeking to transmit, receive, or exchange the data, the type of data to be shared, and the intended purpose for which the data will be used. And all of that gets folded into those data use agreements and MOUs. It's an important piece of responsible data sharing, as state and federal laws must be considered, regardless of whether a data use agreement or MOU is utilized. And there, of course, you've probably heard of a lot of the limitations in federal law associated with whether you can share this data with whoever. Under HIPAA, there's protected health information. Under 42 CFR Part 2, there's the confidentiality of substance use disorder patient records. But there are states that have had a lot of success in balancing privacy laws and optimizing data exchanges, affecting a cultural shift in attitudes around data sharing, where they lean more in favor of sharing it versus not. We looked at a number of states. A couple of them are listed here. We also have looked at how these states have overcome barriers, and Georgia is utilizing some of these, but you know, there could be more of a shift in attitudes around interagency data sharing and a system-wide approach. The HIPAA privacy rule has an exception. You can do a limited data set. You can also, as a last resort, always de-identify the data. Of course, identifiable information is the hardest to share. So taking a quick look at Georgia's data sharing framework, all of our state agencies currently share data between one another in accordance with the security and privacy standards set by GTA, the Georgia Technology Authority. We also have the Georgia Data Analytics Center, or GDAC, which you heard from their director at your first full commission meeting several months ago. It was established in 2019. They are an integrated data system with the authority to seek out data from agencies to further research and inform policy decisions. But in Georgia, we are lacking a standardized system statewide approach to data sharing. Agencies don't default to how they share. There's not a standard template that each agency can go to as a basis to start working with the other agency, with their legal departments. They're usually starting from scratch or finding a template that's on file from sometimes many years ago. And so that's just at a glance kind of, you know, there's not a set pathway, and there's also not a entity that is overseeing the process, facilitating the process, or regulating. So some policy considerations for Georgia based off of what we found in other states would be to create a uniform statewide process or system, coordinate development and use of a standardized DUA or enterprise MOU by state agencies, designate an oversight entity to coordinate data transfers from one state agency to another, and determine whether this designated entity is responsible for facilitating and overseeing data sharing between state agencies. If they could also serve as the central data repository that would hold all that data for the state, which could then be released to requesting agencies. One of the points that we have stumbled upon based off of some legislation that was sponsored by Senator Blake Tillery in the 2022 session was Senate Bill 374. If this legislation had passed, it would have caused GDAC to be considered an agent of all executive branch agencies for the purpose of sharing government information was the term in the bill. For HIPAA covered entities, this would have allowed agencies to share information with GDAC without it being considered a disclosure that the agency has to track and report to the federal government. And under the bill, the government information access received or obtained by a GDAC that is protected by any form of confidentiality or privilege would still not be subject to further disclosure by GDAC. The bill unfortunately did not reach final passage. But there's an opportunity to maybe revisit this bill in this upcoming session. And if we were going to consider reviving this legislation, have discussion around that, looking at the role of GDAC and looking at options for empowering that division of OPB would be something to look at. They could play the role of an oversight entity, be the designated agency that all of the other agencies go to, and they say, hey, we want this other agency's data. They could facilitate the transfer. They could determine whether the data could remain confidential and protected. So that's something that we were looking at and presented to Sub-Chair Oliver's committee. And then one other thought finally is establishing in state law an overall presumption of data sharing that every agency is permitted to share with one another. That of course doesn't, that's a workaround for any state law that would preclude one agency from sharing to another state agency, but there will be still some federal law limitations that you'd have to look at. But again, you could have an oversight entity that could help make that final determination or act as an appeal board for agencies that if they have a finding that this is in violation of federal law to share it, they can take another look at that and determine if there's any other ways that they could share the data lawfully. So that was a very fast highlight. I hope it was a helpful glimpse into OHSC's data sharing research and work thus far, and that it is supportive to your work on this commission. Happy to be a resource on this topic, and I hope that you'll feel free to follow up with me or Grant if you have any questions about this presentation or the memo that I believe that y'all also have a copy of.
Thank you very much. Very helpful. And I have discussed our recommendation both with the chair and with Senator Blake Tillery, who is the sponsor of 374, about us moving forward. And I will go into what I think the improvements of 374 I've put forth in the paper. And I've also made some copies of the papers and attachments that I have just for my section, and if I'd like them. I do think that the creation of the one agency that's a sub-agency of every other does remove some legal barriers, and that's the basic foundation of 374. Based on the issues of problematical, just kind of practical issues, I think that the legislation we should consider also including a timetable for one agency to respond to another, 60 days perhaps. I know that they kind of get in standoffs with each other and things go on for a long time. I'd also like to name in the legislation a possible tiebreaker entity. I made 3 suggestions in the report put forward. One, the Attorney General or his designee, the Governor's legal counsel or his or her designee, or Georgia Technology Association or Conde Castellani. Lonnie. So those are suggestions. I do think we need a tiebreaker. I think that legislation also should set forth a requirement of a standard MOU so that there wouldn't be new creative drafting with each agency. It will not solve all the existing legal barriers that we have in federal law or state law about privacy, but it will be a very good start, and it is something that the other states are using in a successful way. So that's a significant recommendation in our paper that you have available to you digitally and in paper. The rest of the recommendations I'll go through at this time all relate to workforce development. How can we get a stronger, more robust workforce development? We know that the loan repayment assistant program set forth in Section 2 of 1013 is a very good start. And I have been in conversation with Lynn Riley and with others in relation to its implementation. As it's drafted, there is some debate going on. Is it drafted only for students who are in college right now, or is it drafted to include the opportunity for practitioners who are in a seat providing mental health services who have a loan outstanding? Can they also apply? I can argue both ways, of course, like most lawyers could, that it's not ambiguous or it's not confusing, but I do think as a recommendation, we should essentially add a proposal that service providers in their seats who are not students today are also eligible for the loan. So we're hoping to move forward with that clarification to expand the loan forgiveness program to more service providers. We also have been asking a question, and I've asked in a paper, do we need to answer this question in legislation, or can student finance make this decision on its own through its own regulation or in some form of executive order from the governor? What is underserved area in Georgia? Is the entire state underserved? One of the rural analysis from Dr. Koch, who's a member of our subcommittee, she does a rural health analysis and specifically for nurses, 150 out of 159 counties have been determined to be underserved, including my county of DeKalb County, where we have a medical school, a $10 billion healthcare entity of Emory, and multiple state hospitals, private and public hospitals. We are an underserved area. So maybe the designation of underserved needs to be articulated by us in a specific way that just confirms that the entire state is underserved. But I don't know that that has to be done by legislation or rule amendment. Those are the kind of questions we've asked, and we've raised them in our report. Another question we've raised, I think some of the federal student loan service provider opportunities require a practitioner to accept Medicaid. I think that's required in some of the proposals. I thought we had included it. I know we included it in our discussion in 1013, and I'm just curious whether that should be lifted up again as a question. As student finance, do they require Medicaid acceptance in any of the other healthcare professional loan forgiveness programs? So loan forgiveness is a step we've already taken, and we are going to expand it in the recommendations I set forth for the full commission to consider. And let me move on to some other suggestions. We know that and all of them, and to a large extent, the rest of the recommendations do represent some funding element. And I think we have to be very thoughtful as we move forward the next 2 months towards the General Assembly and the governor's opportunity to present a budget for FY24 we're talking about now, that there is an extensive amount of reserves and an extensive amount of unspent COVID money. And how much of the money that we're seeking, how many is federal money that we can obtain without state share, without state match, and how much of it requires a state match? I really want to understand that in all of the money proposals we'll make. For instance, we know that the few number of psychiatrists in Georgia is a data point that causes Georgia to be close to the bottom, 48, 49, or 50 in funding. In Columbus, the Bradley Center is making a specific aggressive plan to expand the number of residencies for psychiatrists. And that will be part of a budget discussion. I think it's a good example of a local provider stepping up and saying, we want to build and increase our opportunity to extend services through psychiatrists. Behavioral health workforce study is something that I don't think the Department of Behavioral Health has conducted. I think I have some information. I mentioned earlier about the impact of salary increases, but I don't have information to share with you on the vacancy rates or the turnover rates. And many of the states now have really tried to analyze those basic questions, in addition to what are the other states around us doing in either the private sector or the public sector in salaries? What would a study tell me, tell the governor drafting his budget, that a salary of X percentage does create a solution for some agencies, particularly agencies extending mental health services? So I'm recommending in our report that we have a behavioral health workforce study specifically on the state, and that would include the CSBs, as to what is the impact of salary increases, our salary increases compared to other states, comparable, are we below or above, and what is the real need in a variety of different ways to measure that. DCH is required to give us under 1013 a reimbursement rate analysis, I think, by the end of December. I want to reserve the right, Mr. Commissioner or Mr. Chairman, to comment on that reimbursement rate study. I mean, I'll be able to do that as a member of the General Assembly, but I think it would be a good thing for this commission to look at that reimbursement rate study, because we know very clearly, just as an example, that the intensive bed per diem expenditure for a child in an intensive psychiatric hospital setting is considerably less than the states around us, considerably less specifically than Tennessee, and that we have a high percentage of out-of-state children in our facilities. That seems to me like a data point that would require a very I don't want to say it's a no-brainer, but it just seems to me that that would be something we'd want to address very quickly. We had a good discussion about the realities of enhancing the opportunities for foreign trained health professionals to get licensures in Georgia under a big category of licensures, certifications, and credentialing that we were studied. And I asked all of the healthcare providers, had a lobbyist and an organization to give me, in the mental health field, to give me specific suggestions in the licensure area operated by the Secretary of State, Composite Board of Behavioral Health, and Mr. Briggs Zimmerman came to our study committee meeting, and we had a good discussion. There has been a tremendous increase, obviously, in Georgia's population, and the forms, the mechanism, the procedures for getting licenses has not been modernized. Now, I use that term as a practitioner, a lawyer who now is required to file everything electronically. Original documents are all the courts in Henry County now requiring. I don't send original documents anywhere, whereas the Secretary of State's office requires original documents, original notaries, original checks, the kinds of things that simply aren't a part of our modern business world. So there needs to be a modernization, I would say, of all these different agencies that deal with mental health, if not the others. I used to be a hearing officer for the Secretary of State's office before I got into politics, and I've always kind of followed it closely. And I think that the staffing has not changed at all in the last 10 or 15 years. and the modernization of that whole system has to be addressed. Another part of the licensure procedure is the way in which many of the different mental health providers have practicums or internships that are totally out of line with other states. If you are requiring 3,000 hours in Georgia for a practicum and 1,500 hours in Alabama, and Georgia is an outlier, why are we doing that? And if it's done by the professional association, not the Secretary of State, then let's have a discussion about that. Those are a couple of examples of the way in which our licensure certification is slowing our workforce development and discouraging people to come to Georgia. In terms of the foreign trained behavioral health, that's another specific example. Georgia is, with probably a half dozen states, have over 10% of our population are foreign born. They come to this country as children and they are totally Americanized and they don't even speak the language of their origin, or they come as a young adult seeking a professional position. Because I represent the Emory area in CDC, I'm very aware of the visa program for professionals at that level. I'm frequently asked to do letters of support for a particular kind of scientist coming from someplace. But Gwen Skinner told me that she was using what I think of as the farm worker program, the HN1 program, which is available to her as a private provider to bring foreign trained professionals to work in mental health services. And that is happening nationally. Gwen told me, and she can expand on this, she requires foreign trained daily service providers, sort of the folks on the ground level, to have a college degree if they're coming from another country, whereas if you hire in Kennesaw, it's a high school degree. So it's an example of why the foreign trained population, who is extensively appearing in our healthcare systems, how are we helping with that? How are we creating barriers to that? How do we want to use that as an opportunity? Other states around us, again, in our similar category, Texas, New Mexico, Florida, Nevada, Virginia, they have similar high levels, 10% foreign-born professionals, foreign-born citizens, and they have gotten more structure and more focus on that issue of how we create cultural competency. I heard in relation to one of our speakers that cultural competency, whatever that means in the federal rules and regulation, is coming our way and has to be a part of our thinking in terms of providing mental health services. And I'm very pleased that our subcommittee made that a part of our recommendation. Mr. Chairman, I'm happy for my subcommittee, Cindy Levy, who's very helpful with the committee, or Sally Koch, who's maybe online, to offer any additional comments that they thought was particularly helpful or relevant. We've got a lot of recommendations, and I look forward to working with the commission on a full report.
Thank you. Are there any questions or comments of Representative Oliver?
I have one.
Yes, sir.
This is superb. As both somebody who trains psychiatrists here in Savannah and child psychiatrists, the value of having the support to expand the workforce is tremendous. I think marriage and family therapists are also an important workforce we can develop, and also really appreciate your all's findings about how much more we're requiring in Georgia for people that come from other states than even their master's level training programs require. So thank you very much.
Thank you, sir. You got 124.
Okay.
Hold on.
Okay, so one comment. We actually hired two new psychiatrists through the Conrad 30 waiver. One is from Greece and the other one's from Turkey. So I thought that you might want to know about that. But I did have a comment also about the Georgia Data Analytics Center bylaw specifically prohibits the sharing of information related to mental health and substance abuse, which results from an overzealous interpretation of HIPAA. And this is in direct conflict with the interpretation from the American Academy of Child and Adolescent Psychiatry and the American Academy of Pediatrics, which states that their joint interpretation that only psychotherapy notes that nobody ever does. I mean, this is like a dinosaur from back when people were talking about, tell me about your mother, psychoanalytic psychotherapy, and substance abuse treatment, which I have my issues with that. But we need to start treating mental health like we treat the rest of healthcare, because until we do that, the stigma around getting mental health treatment will remain.
Thank you very much. Helpful, very much. I have the very simplistic term. The reason that the 374 model will help address these, what people talk about as HIPAA barriers, who may or may not be a legal HIPAA barrier. Simplistic analysis, if you're serving the same person, if agent A and agency B are both serving the same purpose, there's no HIPAA violation to share information. And with that simplistic analysis, I think that we can interpret these existing statutes in a more positive, affirmative way. And you've raised a good specific example of how we might do so.
Thank you. All right, with that, we'll add some closing comments and talk about next steps. But before we do that, I just want to, some of you may know this, but I just want to make this comment. Speaker David Ralston had decided not to run for speaker again, but Speaker Ralston, the mother of his children grew up about 2 miles from me. I knew his father well. I've known him. He was my state senator. He was my state representative before redistricting a couple of decades ago. And obviously he was my speaker, and he's been a big part of the mental health reform that's happening in Georgia. But while we've been having this meeting, he passed away, surrounded by his family, his wife, his children, and his brothers. But I just want to say a thank you to him and his family for sharing Speaker David Ralston with the state of Georgia for so many decades. I assure you we would not be where we are today as a state in a lot of ways, especially with the state of mental health really being on the forefront of reform if it wasn't for Speaker David Ralston. So just remember his family over the next several days in prayer. Remember the staff at the House. This is a big loss for the members and the staff here at the Georgia General Assembly, but he is going to be missed by a lot of people. But I always tell my girls, try to live a life so somebody might want to write a book about it. And Speaker David Ralston has lived that life. So with that, I will say that we are going to be sending out the full presentation, all the backup data, an update of that at 9 a.m. in the morning. So that'll go out to everyone here on the commission, both in person and externally. We also have several studies that were prescribed in House Bill 1013 that are ongoing. One of the big ones you've heard a lot of conversation about today that DCH is doing is the reimbursement study, which we all feel like is extremely important to improving the system. That's due in at the end of the year. We also, Georgia State is online with us. I want to thank them and helping us with this process. They're going to work with us and our staff in preparing a report. If it's okay with the commission, what I would ask is, you have heard a very detailed report from each subcommittee today of recommendations. There's a lot of meat, a lot of substance we went through today. Let's give Georgia State and our staff time to put this together in a draft report. Let me send that out to you for review and comment. And when you feel comfortable, then we'll take a vote to approve that report. Obviously, time is of the essence because there are going to be some legislative ideas that we're going to be recommending, and the General Assembly will be in session the second Monday of January. So our leg council partners need to draft legislation if we're going to have that. I also want to just thank Chelsea Nabrit, who has always helped the commission, and Ashley, who is here. And I appreciate United Way and the partners from our nonprofit partners who actually is funding Ashley's position for the commission through United Way. She's done a tremendous job. Camille Taylor for being here with us from House Media has done a great job helping us today. And again, I want to thank the speaker, and I also want to thank Governor Kemp for their leadership in this area. Most of all, though, thank you to all the commission members for all the hard work over the past 3 years and several months specifically. It's a decade of mental health reform, and we got a lot of work to do. So let me just say this, I always like to offer this opportunity. Is there anyone here in the audience that has a comment that they'd like to make from the podium before we close? All right, if not, is there any other comments from the commission members, either online or here in person? If not, let me say that we are adjourning 10 minutes early.